Good morning, Professor Jerome. Good morning. Can you hear me?
Yes, now I have unmuted myself. Can you hear me?
Yes, I can hear you.
Yes.
How is Uganda?
Uganda is okay, but here in Uganda we are on public, it is a public holiday.
Oh,
For Idi Adha, for us it is a public holiday.
it is also public holiday over here.
So how are you are going to get the people? Yes,
We are hoping we are going to get a few of them.
a few of them.
Yes, yes. And others will
Want
join. Others we are
for
hoping will join online.
okay.
Yes.
I
Yeah.
thought people will say, no, that is unfair, especially to people who prescribe to Islam. They say you left them out.
I know, but we couldn't change.
Okay, you couldn't change.
We couldn't change.
And the challenge with Islamic holidays is that sometimes they are not specific or certain dates. Sometimes in advance you
Yes.
may not know.
Exactly, exactly. We didn't know that it will be a public holiday today.
Okay.
Yes. I'm told Teddy, how are you? Teddy? Good morning, Teddy. Okay, yes. Today is a bit chilly in Nairobi.
Okay.
Professor, yes, it's 16 degrees.
Yeah. Mhm. I
Yeah.
was inquiring that can I load my presentation? Share.
What would you like to do?
To share my presentation.
Maybe it's better we wait at, yes, that's okay. That's okay.
Okay.
You can go ahead.
Okay.
We can test the presentation, then exactly at 8:30, you
Yes.
start. Yes.
Hello, Teddy. Hello, Professor Jerome.
Hello.
Yes.
Ye-
Good
yes.
morning.
Good morning, Teddy.
Happy Eid Day.
Happy Eid. Happy Eid. It's still Eid here in Kenya as well.
Yes.
And we are happy you have joined. And thanks for the support. You are saying the volume is low?
No, now it's all fine.
Okay, that's good. That's good. All right.
Yeah,
We say here in Kenya,
functioning.
karibuni sana.
Thank you.
Asante.
Karibu sana. Let me handle the microphone to Dr. B as we get ready. I am on the technical side.
Okay.
Okay. Thank you. I'm asking one of my colleagues to lead us with a word of prayer. Gertrude?
Good morning.
Good morning.
Apiuda. Id Uda Ada. Yes, we are here today and we want to thank our God that He is able to keep us and to make us what He wants us to do. So let us pray. Let us bow our head for a word of prayer. Our Heavenly Father, we thank you this morning for this far that you have brought us. We thank you, dear Lord, for enabling us even to learn that we can do what we are able to do according to your will. We thank you, dear Lord, even for our conference. Whatever we are learning here, oh God, that you will help us to improve our care to our patients. We thank you, dear Lord, even for our country, our institution, our leaders, oh God. Take care of them and give them the wisdom even to guide us in the right direction. We thank you for all your provisions. We thank you for blessing the works of our hands. And my dear Lord, when all is achieved, we have got nothing to give you in return, but just to say thank you. We praise your holy name and we seek your wisdom in all that we are going to do today. Guide us even in the evening, those ones who will be traveling back, oh Lord, and take control of all the vehicles they are going to use. For all this we pray in Jesus' name. Amen. Amen.
Thank you very much, Gertrude. I think now, Professor, you can go ahead and do your presentation.
Thank you.
There's some introduction to be done. Sorry.
Okay.
Good morning, everyone.
Good morning.
And welcome to this is the, this is the third and final day of our conference. And I am hoping that you have learned, you have collaborated, hopefully with somebody that you're going to do some research with. So today being the last day, I'm sure we have the best for last. So let's listen keenly. Our sub-theme today is health research in advancing healthcare. Remember, research is at the heart of our conference and is the heart also of service delivery. Good quality service delivery. So my chair this morning is Dr. B. My name is Dr. Lucy Manyara. So at this point in time, I'm going to introduce our panelist this morning, who is already online. That is Professor Jerome Kabachenga. I hope that is correct.
Correct.
I hope I haven't butchered your name. So he is a professor of public health at Mbarara University in Uganda. He has held various positions in the university. He was the Dean of Faculty of Medicine from 2002 to 2013. He was the director of the Institute of Maternal, Newborn and Child Institute from 2013 to 2024. He's the Ugandan director of the Healthy Child Uganda, partnering with the Canadian institutions, and the co-founder of Micro Research that has been in place for 20 years. So Uganda has been way, way ahead of us. I don't think we have been there that long. So basically, he has vast experience in community research and program implementation. He has conducted several researches and implemented several projects funded by various organizations. So this morning, therefore, we want to plug in and learn. We want to have that experience from Professor Jerome, so that we can learn from his vast experience. So at this point in time, Prof, if you can hear me, please take over the podium. And I want, just before you start, please note all your questions, because after this, we'll have a panel discussion. Put all your questions down, and then we'll give you about 5 or 10 minutes to answer the questions. Thank you, Prof. Take over the podium.
Thank you, Chair. Greetings to you all. And for those who, it is Idi Adua, I would like to send my best wishes. Thanks for the nice introduction. I was given a title to present on micro research in advancing health research capacity and healthcare delivery in low and middle income countries. And as you have already been told, I'm one of the 3 co-founders of micro research, and I'm going to share a few slides about micro research and how it can really advance health research capacity and eventually healthcare delivery in low and middle income countries. Of course, using the experience from Mbarara University of Science and Technology.
Prof. Jerome, let me cut you short. We can't see the
Yes,
slides.
please.
The slides, please load them.
You are not able to see?
The slides.
Oh, sorry.
We can
I
see
thought I
your
was.
PC, yeah, but you can't see the slides.
Oh, how comes that? For me, it is showing me that it is already sharing. Let me see again.
Mm.
Oh. What is gone? I've stopped sharing.
Now we see you. So maybe you can load it up.
Are you able to see my screen?
The screen we can see, but not the slides. We are seeing your desktop.
But it is showing me that I'm sharing.
You're yet to open. Maybe you double click on your presentation for it to open fast.
It is already open from my side.
We
And
still
it is
can't
showing
see
me
it.
that I'm sharing. The alternative is to send them to you and you project them, maybe.
I think so. Just 1 minute.
Yeah. I had this email of E. Kiplagat.
Hello, Prof.
Yes, please.
You can click on once you open the slides.
Yes.
I don't know if you are putting it full screen.
Yes.
Once you have put full screen, minimize the other windows.
Okay.
Or then open the slides, minimize other windows, go to go to the platform and share.
Okay.
When you are sharing, share what you have opened.
But that's what I do usually.
Here it's sharing. It is sharing the folder. It's not sharing the document. So you share okay. Alternatively, you can send the conference then.
Let me send them.
Send to conference at KMTC. There's a, have you accessed the email conference at KMTC?
No, I have E. Kiplagat.
Yes, okay, it's okay. Send it to E. Kiplagat.
Okay. Just a few minutes. Sorry for that. I have sent them.
Yeah, we have received. So just give us a few minutes to load it.
And I should stop share this side.
Yes, you can stop share that side. We are now on, Prof, you can see. Sorry, it's gone back. I think we're good to go now. The slide is on.
Yes, thank
Are
you. Apologies for that sort of mishap, but sometimes these things occur. So we have already spent a bit of time while trying to fiddle with the technology. Next slide. As you have been told, I work with Mbarara University. It is a public university that was started in 1989. It is located in the southwestern part of Uganda. In that area, you can see where Mbarara is. We are closer to Tanzania and even Rwanda. The university has 4 faculties and 2 institutes. It has Faculty of Medicine, Faculty of Science, mostly concentrating on training of science teachers for secondary schools. Then it has Faculty of Computing and Informatics. It has Faculty of Applied Sciences and Technology. Then the 2 institutes are the Institute of Tropical Forest Conservation, which is in the far southwestern part of Uganda, closer to northern Rwanda and the Democratic Republic of Congo. And we have the Institute of Maternal Newborn Child Health. The student population is about 8,000. And as you can see, the student population being at that is because it is specifically a University of Science and Technology. And of course, as when you are in that area, you cannot push up the numbers very fast. Next slide. Now, the origins of micro-research. The 3 co-founders of micro-research are those. The topmost is a top photograph is Professor Noni MacDonald. On the right is Professor Bob Bartolisi. And I think these are the people who I'd say they are the people who incubated the idea and started it off in 2008. And Bob and Noni had come to conduct a workshop in Mbarara University of training us, the lecturers, in basic research methods and skills. And that's how the idea was born. And the origin was that we were seated down and they were asking us, they were asking me especially, what could be the problem why most of the lecturers, the teachers were not involved in research. And I explained that the challenge was, first of all, most of the lecturers, teachers were not having enough research skills. And two, the funding, because what was available then were the big international grants, and people would not really have the opportunity to apply for those grants unless they have done some basic research and they are able to use the results to apply for bigger funding. Next slide. As you know, most of the research is done in high-income countries. And even in our countries, most of the research that is done is funded research, whereby in most cases we do respond to calls which definitely are focused on the interests of these foreign funding bodies. And as a result, there is a research gap, both in the skills and even in the funding to answer the questions that we are more concerned with. So we end up doing research in most cases, which is a priority of the others. Next slide. I'm sorry, some of the slides I will be a bit faster. So in coming out with micro research, we copied the model from microfinance, which was championed by Muhammad Yunus, who is a Nobel Prize winner. And I'm told now he's, I think, the president of Bangladesh. And it was based on giving small loans with ambition and enthusiasm so that people could start up some small businesses, and they were offered with the coaching and mentoring, and it never required a correlator, and it was found out to be successful. So that's how the idea of micro research was born, that if we manage to get small grants, but of course it would start with training, and by that time it was the training, the capacity of lecturers, teachers. Then they are eventually given those small grants. They implement a project up to the level of having it published, and then it can, those involved would gain the best skills, then they could answer local problems, and eventually they can also advance in their research career. Next slide. This, as you all know, there was a Bamako conference in 2008, and it was really trying to promote research for health. And it was coming out that there was need really to strengthen the capacities of countries and different regions to do their own research. And it was recognized that in most of low-income countries, they want to control their own research agenda. But then there were other issues which were there. They needed to be assisted to build their own research. And this research would help in informing policy. Next slide. And that aspect of owning our own research and be able to focus on our local problem is what is termed as decolonization, trying to take care of our own research agenda. The the priority of the research and innovation, especially the primary health care, the research at the lowest level, is the research that can help us. And then too, there was need to improve capacity to implement research policies. Once you come out with research, then translating it into policy is another stage. And of course, there was that aspect of trying to promote evidence-based policies, that our policies in Africa especially should be based on evidence. And that Bamako conference, there was a pledge that countries can be assisted through the collaboration to build and strengthen research for health capacity. Next slide. Now, from 2008 to 2010, there were economic turbulence, and that affected the years after 2010. Our economies were not, even those of developed countries were affected. And more recently, we are all aware, we are faced with the pandemic. That one again brought in some other issues. And the other big factor is that the high-income countries are relatively fixed on in as far as global health research is concerned. More so, like you have seen, one of the biggest global research funder is United States, and as you are all aware, there are big changes in that area, and as far as funding is concerned, it has been sort of suspended in most areas, and we are already feeling the effects of those changes that have been effected in the United States. Then back to us, still there is lack of capacity to do independent research, and more so, we lack local mentors and people to coach the people who are interested in carrying out research. And the biggest of all is lack of funds to do local investigator-initiated research. You will find that still, let it be from Europe, from other countries, you find that we are still depending on these calls which come from other countries where the money is coming from. Next slide. Now, in 2010, there was some needs assessment as we had started this micro-research collaboration. Questionnaires were distributed to academics and junior healthcare faculty. And these were in the 3 countries of healthcare professionals of 3 countries, Uganda, Kenya, and Tanzania. And it involved both quantitative and qualitative questions, multiple choice questions, and there was a 70% response rate. So what did we find? Next slide. One of the questions was what were the 3 biggest healthcare challenges? As you can see, the biggest was health services access, followed by social determinants of health. Then the services, the quality of health services themselves, and then funding. Next slide. Then a question was posed. What were the 3 biggest challenges to developing health research in your region and country? So the biggest challenge to developing health research was the health researchers, absence of health researchers, 27%. And next, of course, there was lack of knowledge and skills Then the third was funding, then implementation and infrastructure. Next slide. Then the question was posed, but if there was $1 million for health research, how would you like it to be distributed? As you can see, most people said that the biggest chunk should go to community-based research, followed by health systems, then epidemiological, clinical, and clinical trials and clinical observation, as you can see in that pie chart. Next slide. Now, it was brought down to $100,000. If you are to help a university health faculty to become involved in such, how would you distribute it? As you can see, what is important there was the blue piece or chunk of the pie chart, young faculty. And if you combine those, they were saying undergraduates and graduate residents, it came up to almost 73%, indicating that there was need to prioritize resources to low-level cadres within the institution so that they build up their capacity to drive the research agenda. Next slide. Now, if you reduce that money to 50,000, that can be available, and that is similar to like our environment. We may not get those $1 million or hundreds of dollars, but if you got like $50,000 available to support research, how would you distribute it in terms of the numbers of projects? You can see that giving that 50,000 to one researcher got zero. But if you gave $22,000 grants, that's where it would have impact. In other words, you would have small grants and you reach many. Next slide. Now, when you go to low-income countries, knowledge and knowledge translation gaps, in Africa, you find that new knowledge is often not implemented because, like we said earlier, most of the proposed changes do not fit the local context or culture. And also, you find that there are lack of local champions, people to really champion this new knowledge that has been generated. And of course, you may have other things like saying that there are no resources and other sort of reasons that one can give. But as people who also are involved in research, we should know that for donors and governments, they are pressed with direct demands that take precedence over change and what the people may want to be done at that material time. So as you can see the list below, there are those issues which are ever there: TB, HIV, famine, malaria. Then once in a while in our environments, we get epidemics like those of Ebola or floods or other issues that derailed some of these sort of agendas that we set. Next slide. Now, when we got community health focused research, like as you saw in that pie chart, most people would like to have that community focused research because local health problems need local solutions. So in other words, solutions need to fit the problems. So it is the local health professionals healthcare professionals and community members who can identify these problems, and they apply research to find solutions. And in our thinking is that it has the highest, greatest impact, potential impact in any country's practices and policies. Next slide. So our experience of micro research is that since 2008, it has been community-based, driven, and of course, it has had some community benefits. We have the local universities, hospitals, and training sites, and it has some element of being sustained locally so that we can solve our own problems. Next slide. I think some of you have come across this picture, which shows the difference between the reality, which is on my left. Then you see quality, especially for this vulnerable gentleman with the dark blue t-shirt. Then you have equity. Then we have a liberation on the right, where you don't have any of these barriers. So we think micro-research is practical, feasible, and it decolonizes and democratizes community-focused research, and it should be embraced by our institutions so that we are able to solve our local problems. Next slide. And here by decolonization, we mean that the local community owns leadership for this research. Then democratization, we mean that we should spread our research capacity so that we involve all stakeholders when we are doing our research, so that research is not seen to be done by people in training institutions, but they become part of the research process, and when the results come out, they are able to also own them. Next slide. And micro-research has those 5 pillars on education. Of course, once you educate people about to research, but then there has to be some funding, seed funding, to allow them implement that research. And all this is aimed at changing the mindset. But we have to be in mind that there has to be credible science. And with like most people who are involved in training, there has to be some aspect of volunteerism. You don't go into research to say that you are going to make lots of money. You are focused on finding solutions or answers to a problem. And once you get the answers with the colleagues, you share it with the people who might be able to do something about that problem. And then eventually you improve people's well-being. Next slide. Next slide. This is the famous table. And the first box there, or rectangle, is the micro-research workshop, which usually takes about 2 weeks, where the teams are composed, then they form, they come out with a research question, they resolve research outline, which receives first critical review by the end of the workshop. Then the proposal is developed, and once approved, then it receives funding of about 1,000 US dollars. That one is a typo. The Canadian dollars was supposed to be 1,500. But now I checked this morning, 1,500 Canadian dollars is now equivalent to $1,000. Then, of course, there are the local clearances of research ethics or institutional review board, or some cases in certain countries, you have to get a national clearance. The team carries out a project, and definitely afterwards, the team is expected to translate the findings to the community or to change practice, or in some cases, if you are able to also influence policy. And of course, there is that aspect where you need to share your findings with the bigger community, that is by publishing. And of course, there is, along the way, there is coaching and e-module learning. Next slide. I can see I've already gone beyond time, but in summary, up to last year, you can see micro-research was in 10 countries, had already more than 500 volunteers. We have held 72 workshops, 1,514 participants, and 189 projects had been approved. And by that time, we had 48 peer-reviewed publications. Now, the participants, you can see them. There are different participants, social workers, statisticians, allied health, pharmacists, then healthcare workers, and the like. Next slide, please. Now, this is an example of one of the projects where Aisha's team did a micro-research on why babies die in the first weeks of life, in the neonatal period. And then you had Florence, who had also done a study about the traditional cultural practices around pregnancy and childbirth, and more so about the issues that were concerning how they clean the umbilical cord. Next slide. From the two studies, they contacted a pharmaceutical company, and they developed a chlorhexidine gel. This gel now became part of what are called mama kit or mother kit in Uganda. And this one has helped to reduce neonatal death in Uganda. So the two micro-researchers were able to come out with a product that now has eventually become part of the mama kit and has helped in reducing newborn death. Next slide. And from a survey we carried out in 2016, we were asked about questions: how did micro-research impact your career? You can see the high percentage. And we found out 85% people were still involved in research. And those were the different sort of people by way of their professions who were involved in research. You can see it is a multidisciplinary sort of composition. Next slide. Now, this is micro-research networks. This is the global sort of network, as you can see, in different continents, different countries. Next slide. And here was an example where micro-research, which started in Uganda and then spread to the region, now has gone back even to be implemented in Canada. So there are things that can be started in our environment and end up also spread to the other parts of the world. Next slide. Now, these are comments about social accountability and equity in action. where we say micro research democratizes research by placing research skills and opportunities in the hands of people who live and work in their community, and by empowering local researchers. The decolonization research leads to changes in the health systems of community and of country. Those are quotes from the different participants. You will read them when you get the slides. Next slide. Now, these are the partners and some supporters, but mostly you can see those in the right-hand column. You are able to see all the institutions which are involved in micro-research, and even some on the left side you can see in Rwanda, in Ethiopia, and of course the Healthy Child Uganda and the like. So I would like to stop here and thank you for your attention. Over to you, the chair of the session. Thank you.
Thank you so much, Prof. I think we have learned. And just before I take on the questions, allow me to just a quote from Mother Teresa, who said that if everyone swept their door, the whole world would be cleaner. That means if you did your bit, then we would have a very nice world, health-wise, socially, physically, and all that. But a few highlights from Prof's presentation, that we have to make research a priority for us. Are we doing that? Just in our very small ways. Small loans, big dreams. That's what he said. Small loans, big dreams. That means micro research yields big change in healthcare, in health service delivery. And then micro research slowly builds capacity. So it is a snowball. So if you're trained, then you train the next person. So it is not a one-time, you're trained, you do your research and that's it. You train and you move on to train the rest. You become the mentor, you become the coach. So we have small loans for greater people so that we do many researches, but locally focused. Then local problems, local solutions with great impact. And then the question is, where do you get these topics for every day to do that micro research? Every day we are doing service delivery. So what problems are you looking at? What are your pain points? Because that's when you get your research topics. Are people dying, like these children who are dying, newborns who are dying? Is there something that you are observing every day? Those are the things that you need to pick, and that's just a topic. So don't look for topics out there. The topics are within what you already have. So at this point in time, thank you so much, Prof. We have heard, we have listened, we've seen the impact of micro research, and I'm sure this is going to really skyrocket our research capacity and even the funding, because the funding is usually the problem. But if we have those small fundings, but can be given to many, then we can do a lot of research. So at this point in time, I want to ask for any questions from the audience and from the online audience so that Prof can take it up. Questions? Okay, one.
Thank you so much, Prof, for the wonderful presentation. My name is Laban Makori from KMTC Kisii campus, and I have a quick question with regard to the funding model that micro research is encouraging, where you talk of up to 75% of all the funds going to the undergraduates, the graduate students, and the junior faculty members. I don't know if you have an example of where this has worked successfully, from where KMTC can benchmark and have an implementation that will help our research move faster? And the second question is, you talked about equality and liberation as the direction that we're moving, and noting so well that primarily we have inequalities that are existing that we may not really get to overtake. And it's the reason why a lot that is being done is in reference to equity. I don't know if you can share on how micro-research is ensuring that there's equity that will ultimately lead us to liberation, so that we don't have the aspects of the inequalities that are making difficulties when it comes to doing this. A practical example is of, let's say, KMTC, where, for example, you realize that we have campuses that research is probably unheard of, and we have campuses where this is an excellent program. So that's already an inequality, and equity should be applied so that we move towards liberation. Thank you.
Can I respond to that question?
Maybe you can pick two more.
Okay.
And then you
Okay.
pick.
Okay, please. Okay.
Yes. Yes. Thank you, Prof. Kabachenga, for that nice presentation. In fact, I used to think that micro-research began in Canada. I didn't know that it actually began in Uganda. That's something I'm learning today. Now, you said part of the problem with research is reliance on the external funding. And we have seen what can happen with the time Trump has come into the scene. Having been the founders of micro-research, particularly at Mbarara University, have we moved any step, perhaps, in terms of being able to get any local funding into the micro-research, or we still rely on Micro-Research Canada for the funding?
Okay.
Thank you.
Prof, you can take those two, and then we can give you two later.
Thank you to the questions that have been posed. Now, the first question was about the model whereby I said this was an assessment, and they were asking the participants, if you had money, who would be your priority in allocating these research funds? And the participants said that they would prefer, and these were institutions, healthcare institutions and training or teaching institutions. They would prefer this money to go to the junior staff, the undergraduates, and the junior lecturers or tutors, so that they build the capacity from down. Because the senior people are in partnerships where they are with other researchers and they are able to raise their own research money, but it is usually the lower levels that are usually having problems. So it is not here that it was the actual allocation, but it was like a feeling of those who participated in this study that most funds should go to those levels. Now, equality, equity, now it comes to us where we are in our institutions. I was reading on the KMTC website on the research area where there is a strategy to improve research capacity of the lecturers, the trainers. So this one also should be reflected in the budgets on how funds are allocated. And even if you allocate to training, then you should also prioritize which group needs more training. The senior people should be charged with the most senior people with looking for external funding, and sometimes even writing proposals that can help to strengthen the capacity of research. So it has to come to us, we have to own it. By the way, in Kenya, I was told you already have county governments. I hope the county governments would be responsive to solving local challenges if they are presented with evidence. And maybe there's a need for us also to leave our institutions and try to lobby with these people who hold the money passes so that they try to help in funding some of these initiatives. And more so, like we are seeing big countries, they are taking them priorities of their own people. Even us here in our environment, we have to consider that. Now, reliance on external funding. Where we started in 2008, we have been receiving support from Micro Research Canada of the small grants because we still have challenges of sourcing local funds. But locally in Uganda now, there's now the government for the last 3 years has been allocating money for research to universities. Of course, the big university, Makerere, takes the biggest chunk, and we get some money to give to research. And what the university does is that the money is given in form of small grants also, which are about $4,000. And they also, whereas it doesn't have the component of training like we have in micro research, but people who have participated in micro research come together, form a team, and apply for that funding. Then another aspect that we have ever also been able to get funding was that one of the participants in micro research did see an opportunity for medical education and training from National Institutes of Health of USA and wrote a proposal to train undergraduates in micro research. And the teams who qualified for that funding were from the different health professions training. It had to be multidisciplinary, and they underwent training following the micro research curriculum. And eventually they have had about maybe 40 publications as undergraduate students being mentored by some of us, the senior people. So you can also write grant applications and win research grants and follow the micro research sort of approach to also achieve the objective. Thank you. That's what I can say as of now. Yeah.
Thank you, Prof, for those answers. So 2 more questions from the online audience. The first one is this. I'll just read it. So what mechanisms can healthcare institutions put in place to ensure that micro-research projects contribute meaningfully to service improvement and patient care? Again, I will read it again. What mechanisms can healthcare institutions put in place to ensure that micro-research projects contribute meaningfully to service improvement and patient care? The second one. Thank you for the discussion on decolonization research to address the existing gaps. Any comments on the local realities around ethical review committees? Again, I'll take it again. Thank you for the discussion on decolonizing research to address existing gaps. Any comments on the local realities around ethical review committees? Please take those up.
Thank you for the questions. The first one, I think it all starts with the research problem that one or the team identifies. The problem should be the problem that is affecting the service delivery, such that by the time the team tackles that challenge or that problem, then the results will be received and then put into use. So I think it starts with the problem that you are trying to address. So the team has to address a priority problem, and of course involve different people or different from the different sectors to come together, tackle the problem, come out with findings, share them with those people who are able to take the decisions, and definitely once a solution comes, then the people will respond to it. Just 2 days, we had the permanent secretary, Minister of Health, and was visiting us. We had a chat with her, and that's the same question that comes. That they are committing. They have many problems which require evidence, which require people to come and provide tangible evidence, and then definitely they work on it. So one has to look not what the Americans, the Europeans, or other people are interested in, and then you follow it, but you have to look for the local problem that is really, if at all the answers come out and then they are able to address the problem, definitely the people in positions of responsibility will take action. So I think it starts with the challenge that you are trying to address. Any local realities about ethics review. One of the issues we had in our country, the local research ethics committee or board, you have to pay money to have it cleared. And then we have the national clearance. Also, you have to pay. At each of those levels, we were expected to pay 300 equivalent of 300 United States dollars. At the institutional level, we were able to put our case, and they were able to waive the fee. No, not to waive completely, to subsidize, to reduce it to 50 US dollars. And for the National Council for Science and Technology in Uganda, for those ones, they have remained adamant. Because they claim that, okay, they state that the reviewers have to be paid, so we have to pay. So you find of the funds which we get of micro research of 1,500, you have to chop off 350 to clear ethical review fees. Then that is one aspect. Maybe the other challenge that comes with the clearance of the proposals is the time it takes. It takes a bit of time at the local review, institutional review board, and of course at the National Council for Science and Technology. And mostly there, it is issues of ethics and the scientific merit of the proposal. Those are the two areas. But the biggest challenge has been chopping off that $350 for catering for the clearance fees. That has been the major obstacle. We have put our case to Uganda National Council for Science and Technology, but up to now we haven't succeeded. And this one was really not being welcomed by the sponsors who give us that micro grant, and then you have to chop off that money. Yeah, that's what I can comment on the two questions.
Thank you so much. Thank you so much for that. And I'm hoping we have put in down our notes as we continue doing micro research. At this point in time, I want, before I come to you, Prof, for your parting shot in 30 seconds, I want Teddy to make some comments because she's been involved in micro research. Teddy?
Thank you so much, KMTC, for inviting us and involving us in this conference. And thanks to Prof. Jerome for elaborating very well what micro-research is and how we can benefit from this approach. I think it has all been well said, but when I look back, and see what we can do and how we can do things differently, I think it's the heads of institutions to change their mindset around small grants versus big grants, especially as Prof has really put it properly. You can't get the big grants unless you show that you have experience. What I have seen is that much as we graduate and have the masters, we do those things because we have to pass and get our degrees. But then when it comes to micro research, it really grounds you into how do you even apply for ethics approval. I have seen that as a challenge. Things have changed. Some people use it to do paperwork and now it's online. So you go through that with a small grant, with a mentorship around you, and you're able to advance. So the mindset of the heads of institutions, so that we appreciate that micro research can contribute and help us to get into another level. Then another thing is that, of course, if we are to move, we have to provide funding for training. People have to be trained. They have to go through the 2 weeks training and create teams. Of course, even when you're doing research, it's hard to do research alone. So micro research provides that platform of enabling you to learn to work in a team, and then also to be able to associate with some people that you can, apply with, even when there is an opportunity for a bigger grant. But all in all, I think as institutions, we have to appreciate the micro research methodology and embed it in our research strategies as one of the ways that will help us mentor the junior faculty and the students so that they grow up appreciating and not fearing research. Because for me, when I was, at bachelor's level, the issue was like, even if you pass exams, are you going to be able to pass your research? So there's that fear, and with micro research, you get out of that fear and you're able to face it all. One of our colleagues was telling us that when they were interviewing her for promotion, the first 5 publications that she had were from micro research. And they were asking, how many grants have you won? The first 5 grants were micro research grants, and she was able to be promoted along those lines. Someone has a question online, and he's asking about the credibility of micro research. It is so small. How about the rigor, and how can you use that to influence policy? Prof has already given one of the examples. These are researchers that go through the ethics approvals. For us, we do institutional and national approval, and then you have all these support from your mentors and your coaches, both local and international, and that provides that rigor. And I know Ivan is online. He was telling me how he used his small study, which he did in one of the districts, around the quality of bed nets. We used to have bed nets that were so hard, and sometimes they would even like stick. But he used his research to approach people who were in charge, and they were able to improve the quality. Now we get to the soft bed nets. For us, we get bed nets in Uganda every 5 years. So I think the rigor is not an issue with all the support that you have, and the fact that it goes through micro research, goes through the ethics approvals. Then also, I know in micro research, some of us haven't appreciated very well the knowledge translation bit. So that is where you're able to engage, even at community level where you collected the data, so that they're able to use their own results. And I see that it's not about I go back and disseminate the results. If they decided to do something differently, are we able to make a follow-up? Sometimes maybe things happen, but because we stop at doing dissemination and that discussion around what are you going to do with the results, and you don't go back, then you're not able to track what was done differently following the micro research results. Then also we have a regional hub, and we happen to be the coordinators of the regional hub. We call it Micro Research Eastern Regional Hub because we have Malawi, Kenya, Tanzania, Rwanda, and some sites in Uganda. And I think what I'm hearing from these presentations and the questions is that what can we do more as a regional hub to be able to mobilize resources that the different countries can tap into to be able to do studies that matter to their populations. I think maybe in our next meeting, the coordinators, that is something that we can discuss, apart from the monies that we get from abroad and the monies that we, get from elsewhere. As a hub, what are we doing to be able to, generate, create some funding that we can use for the different sites to be able to improve micro research. Otherwise, I thank you so much, and thanks, Prof. This was really a very good presentation. I hand over back to the MC. Thank you.
Thank you. Thank you, Teddy, for those additions. Well received. At this point in time, I want to just go back to Prof. 30 seconds, your parting shot, and tell these people what they can do from here, what they can take home, where they can start. Prof, over to you before I give it to Dr. B.
Thank you. My parting shots are that, as you can see, where we started, it was to improve research capacity at the institution where it started, and eventually we are able to see that the people who were trained over time have advanced from. They are still involved in micro research as mentors, but they have advanced to become independent researchers, to apply big grants, even some, they are not, first of all, to even advance in their careers from whatever level they were to up to, some of them have attained PhDs, and they are able even to apply for big international grants. So what is important, I think, for KMTC is that, and I see you have so many campuses, some are a bit more so ahead than the others. So the ones which have gained or already have advanced in micro research can help support the other campuses using the micro research principles and supported by the hub, so that we increase the pool of researchers. I mean, there are people who are saying now, can you have the rigor of things like clinical trials and randomized trials and so forth? Yes, but there has to be a starting point. And of course, you are not going to design a research question which requires a RCT and you base it on that 1,500. But before you reach that level, there are some basic questions around us, basic challenges which we can solve. And you need to use these basic skills with mentors, and then eventually you ascend the different levels in research. So it is about building capacity, and also to have that idea of not only looking for those big $1 million grants, that using the small resources we have, we can answer some questions. And those same skills will be used for the bigger grants, and they can help you to develop from one level as a researcher to the next one. Then you help those also behind you. And for us who are in the training institutions, then you share the knowledge and skills with your students. I guess there should be some of these programs you are offering that also require students to do research and come out with the dissertations, or research reports. So the skills, I think the focus should be mostly the trainers, the lecturers, the tutors, the instructors to come together and get those skills. And those skills can help them even in teaching. But to me, the issue of small grants is to start off priming grants, to make people take off in their research career. Eventually, then you can even use some of those researchers when they are writing the big grants, and the people who are reviewing will see that these are people who already have skills. If we give them this money, they will implement this project. I think I've used more than my 3 seconds. I would beg to stop here, and thank you.
Thank you very much, Professor Jerome. Thank you very much, Teddy. Micro Research Uganda has been with us, held our hands in so many activities from the first time we participated in micro research training under the University of Nairobi. And now we are very happy that micro research is fully at KMTC. We have had 2 cohorts of lecturers from all over our campuses. And what we are doing is to capacity build the lecturers so that then they can move it to their colleagues as well as the students. Those with the certificates, after you have completed the training, you are allowed to apply again. You get another group and you get a small grant. And some of the people that we need to involve, once you have the certificate, get the students. They do that small grant, it sets you off, as you have been told. So I don't want to take a lot of time. Thank you so much. Be blessed, and thank you for bringing the team, introducing us to Malawi, introducing us to Rwanda, introducing us to Tanzania. Thank you very much.
You're welcome. You're welcome.
We now move to the next phase of this session. So in this session, we have 5. We have 5 presentations. Remember, we are at the theme or sub-theme, Health Research in Advancing Healthcare. So I'm going to introduce the speakers, and I'm hoping the speakers are all here. Munyoki Nyamai. I'm hoping they are here and that their slides are already on board so that they just come and do the presentations. Munyoki Nyamai. Grace Achieng Otieno. So I'll give this point to Grace Achieng Otieno, and she will be presenting research, a point prevalence survey of antimicrobial use at the Kisumu County Hospital, Referral Hospital, by Grace. Please note that we will take questions at the end of the presentations. So our online audience, our physical audience, put in your questions for all the presentations, At the end, they will all come and sit here so that we can take the questions. So Ochieng, over to you. Okay, O and O, A and O, it's a problem for some of us.
Good morning. My name is Dr. Grace Otieno. I am a lecturer at KMTC Kisumu campus. I teach pharmacy. I'm going to present on a point prevalence survey of antimicrobial use in a study that was conducted at a Kisumu County Referral Hospital. Kisumu County Referral Hospital is a level 5 facility based in Kisumu town. This work was done in collaboration with pharmacists from Kisumu County. That is Dr. Roger Somolo and Dr. Michelle Okumu, and also pharmacists from USAID MTAPS program, which is a USAID Medicine, Technologies and Pharmaceutical Services program. And the research was funded by USAID MTAPS and it was done in October 2023. We can move to the next slide. So to introduce the study, before we go to the PPS survey, we have to look at why we did this research. And the reason we did this research is because of antimicrobial resistance. Antimicrobial resistance is a global public health problem. In a nutshell, it is when microorganisms that were previously responding to antimicrobials stop responding to them because they have developed mechanisms of evading these antimicrobials. The main cause of antimicrobial resistance is inappropriate use of antimicrobials, both antibiotics, antiviral drugs, even drugs for protozoa. So, and inappropriate antimicrobial use occurs in various facets of our society. First, in the environmental sector, how are we disposing antimicrobials? How are we disposing waste from consumers of antimicrobials? For example, those who take antimicrobials, where does their urine go? Because the antimicrobial is excreted through urine, through feces, where does the sewage go? Is it exposed to the environment? Another area where we use antimicrobials inappropriately is in agriculture. Irrational use of antimicrobials by our farmers, irrational use of pesticides in poultry farming, in livestock farming. And also, the third place is in our healthcare facilities. How are our prescribers prescribing antimicrobials? Is it appropriately or not? So this study was interested in appropriateness of use of antimicrobials in a healthcare facility. And that healthcare facility was Kisumu County Referral Hospital. So we can't know how we're using antimicrobials in the facility without data. So the World Health Organization developed a tool called Point Prevalence Survey Tool that helps the healthcare facilities to analyze how they're using their antimicrobials. Is it appropriate or not? And this tool has been used in facilities all over the world, but not so much in sub-Saharan Africa. Next slide. So this tool, the overall goal of doing this kind of studies is to come up with data that can help in the containment efforts of antimicrobial resistance. Okay, next slide. Okay, so the methodology was basically using the World Health Organization PPS tool. This tool can be found online. This tool looks at the number of patients in a facility, how many on a particular day. So you choose a particular day. On that day, how many patients are in that facility? How many of those patients are on antimicrobials? Which antimicrobials are they on? What is the duration that has been prescribed? Is it appropriate according to the indication? So that's exactly what we did. So we selected a day, and on that day, we reviewed all the patients in that facility. So on that particular day, we had, in this facility has a bed capacity of 189, and we had 140 admitted patients on that day. The occupancy was about 74.1%, which was less than the total capacity. All the wards were not fully occupied, with the exception of the psychiatric ward, which had a capacity of 211%. So that was double the capacity of that ward. So let's look at what we are concerned with, which is the antimicrobial prescribing. Again, you look at all the wards. With the exception of 3 wards, that is the maternity and the pediatric and the psychiatric ward, all the other wards had more than 50% of the patients were on antimicrobials. So psychiatric ward, of course, for the obvious reason that the patients there may not have infections as such, but all the other wards, we were using antimicrobials. So then we ask ourselves, are we overusing antimicrobials, or was the prescribing appropriate for all those patients? Next slide. Again, we looked at how many antimicrobials were prescribed. That is 121. And the duration of prescription, those with 5 days were the most, and then some had more than 7 days. Why is this important? It's important because we want to see if we're using it appropriately. Like if you underuse the antimicrobial, then you expose the microorganism to the antimicrobial. But again, that exposure is limited. The microorganism will learn how to evade that microorganism. So we want to know, are we prescribing it for the right duration? Next slide. Next slide, please. Okay, so then we looked at the the molecules themselves. So again, WHO classifies antibiotics into 3 categories. The access antimicrobials, those are the ones that are supposed to be readily acceptable. Usually they are narrow spectrum antimicrobials, and they are first line and second line for most infections. Yeah. And then we have the second category as the watch category. Those are supposed to be limited for certain infections. And then we have reserve antibiotics, which are limited to when the access and watch have failed, then we move to the reserve antimicrobials. So we want to see from our antimicrobials in this facility, which ones were from the access, which ones were from the watch, which ones are from the reserve. And as you can see, the most prescribed antimicrobial on that day was ceftriaxone, which is a watch antibiotic. Okay. WHO says that 60% of antimicrobials prescribed in a facility should be from the access category. But as you can see here, in that particular facility, 2 of the 3 most prescribed antimicrobials were from the watch category, not access. So it means that our prescribers are not aligning with the guidelines for treatment of first line, like first line and second line drugs. They are choosing to move to the watch category instead of using the access antimicrobials. Next. Again, this is just breaking down the antibiotics according to which ward and what was prescribed. But overall, ceftriaxone was the most prescribed in 5 out of the 8 wards, and there was even a reserve antimicrobial in the surgical ward. Next. Okay. So overall, We can just move to the last slide. Yeah, so from this study, we were able to see from this one county referral hospital that there's an over-reliance on antimicrobials from the watch category instead of the access category. So we advised the facility to come up with guidelines for use of antimicrobials and to also have continuous medical education for the prescribers so that they can have refresher knowledge on the access antimicrobials and what they need to prescribe first before going to the watch antimicrobials. And we also were able to advise on the procurement of antimicrobials, that the pharmacists should procure the access first before, should spend most of the budget on the access antimicrobials instead of the watch and the reserve antimicrobials. Thank you.
Thank you, Achieng. I hope that's the correct one. Thank you, Achieng, for keeping the time. So I want the other two presenters to please come over. That is Anna Sabisa, Emily. Emily? Anna? Where's Anna? You're Anne? Okay. So Anne Sabisa is going to talk to us about effectiveness of epidural block in management of labor pain among women attending maternity in Kericho County Hospital. Please take over. You have 8 minutes.
Okay, thank you. I'm standing on protocols observed by previous presenter. Good morning. I'm Anna Sabisa, a lecturer in nursing department from KMTC, Kisii. As I'm waiting for the presentation, if we have looked at the Bible, in the book of Genesis, when we defiled the laws of the Garden of Eden, women were given a consequence, that is they will labor in water, in pain. And for the women who have bore the curse, they can agree with me that the labor experience and the curse is heavy and huge. But thanks to the wisdom which was given to King Solomon and the knowledge, we have modern Solomons who have advanced management of the labor pain. And we are seeing light that at the end we are going to get liberation against the curse. So my studies got one of the ways of managing pain in labor is by use of epidural analgesia. My study, I'm going to present on effectiveness of epidural block in management of labor pain among women attending maternity in Kericho County Hospital. Next slide. Introduction. We see that effective pain management during labor is essential for maternal comfort and childbirth outcomes. And epidural analgesia has been recognized for its efficacy in managing labor pain. But if you look statistically, globally, you find that 60 to 70% women in developed countries use epidural analgesia. But in sub-Saharan Africa, the uptake is in 10%. And in Kenya, epidural analgesia is restricted in tertiary hospitals, and we have seen uptake of 5%. We go to the next slide, which is the problem statement. So in Kenya, including Kericho, where studies indicate that many women experience severe to unbearable pain, with a significant portion finding the pain worse than expected. So epidural has been adopted to manage the pain, but we have debates on its perceived efficacy, safety, and overall impact on the labor experience. So this study is going to evaluate the effectiveness of epidural analgesia in managing labor pain in order to address those critical issues. Let's go to the next slide. So we have seen that labor pain management is going to significantly affect maternal and fetal outcome during childbirth. That's why it is essential to note that the choice of effective analgesia can enhance the labor experience, reduce stress, and potentially improve maternal and neonatal outcomes. Comprehensive evaluation of epidural analgesia is lacking. That's why this study aspires to improve maternal and neonatal health outcomes by analyzing pain, relief outcomes, patient satisfaction, and potential complication. Let's look on the next slide, which has the study objectives. The broad is that to evaluate the effectiveness of epidural analgesia in managing labor. And the specific objectives we are going to look at is to measure the level of pain relief among women undergoing epidural analgesia in Kericho County Hospital, to determine the level of patient satisfaction with epidural analgesia in managing labor pain, and then to examine the impact of epidural analgesia on maternal and neonatal health outcomes. Next slide, please. So that is the conceptual framework, which is based on the objective of the study. The main or the primary independent variable is the use of epidural analgesia. And we have confounding factors which can affect the outcome, and those are the maternal characteristics and the labor characteristics. And the dependent variable, we are going to look at how the outcome on pain intensity, duration of labor, mode of delivery, and maternal and fetal outcomes. And all those are going to impact on the patient satisfaction. Next slide. So the methodology, I apologize on the study design. It was a quasi-experimental study design done in Kericho County Hospital. Women who had come in the active phase of labor, and the labor should be spontaneous. We used purposive sampling, and the sample size was 80 with a response rate of 93%. We administered questionnaires, and other data was collected on outcome using clinical records. And then ethical consideration was also obtained. We go to the results. Next slide. So the first objective is we are measuring the level of pain, and that is a comparison before and after the administration of epidural analgesia. As you can see, we are using the visual analog scale to rate the pain, which ranges from 0 to 10, meaning 0, no pain, and 10, worst pain. So you can see the percentage before epidural. So 64% of the women experienced a rate of 9 to 10. That is severe pain. But after the epidural, you find that now 68 of the mothers reported that now the pain was at rate of what? 1 to 2, meaning it was no pain, or if it was there, it was very what? Mild. So as you can see, the epidural was effective in controlling labor pain within few minutes, 2 to 3 minutes of administration. Next slide. And then on satisfaction, we have seen 80% of the mothers who participated were very satisfied and 4% dissatisfied. So we can conclude that epidural analgesia improves maternal satisfaction. Next slide. On the outcome, maternal and neonatal outcome, and we are looking at potential complication after the administration of epidural, and 93% there were no complication, and 7 there were some complication, but they were not severe. lastly, the recommendation. So based on the findings, we conclude that the findings of the study support existing literature that epidural analgesia is highly effective in managing labor. And we recommend that the policymakers should make it a standard option for pain management in labor in our public hospitals. Again, the ministry should provide adequate resources for its use. And then we have seen it is available, but the uptake is low. So I'm recommending further research on barriers hindering the utilization of epidural analgesia. And before I sit, I'd like to acknowledge the authors which we did the study with. We have Mr. Laban is here with me, can wave. We have also Dolly Kiende, is one of our students of anesthesia, and we have Peter Masiwo, one of our lecturers. Thank you.
Thank you for that presentation, well presented. I want all the presenters, please come over here. Don't sit back. And if you already have questions for the presenters, write them down and pass it on to the presenters. So in the interest of time, they can be digesting the questions so that once we are done, then they can just go and answer the questions. So our final presenter is Emily. Emily will be presenting on translation and adaptation of stroke-specific quality of life scale into Swahili. So Emily, welcome.
Thank you. Okay, thank you so much. The presenter who was online just talked about in Africa, we have an issue with implementing new knowledge. So this topic is talking about translating a standardized outcome measure, which is normally used to adapt to assess the quality of life among stroke patients. So this is a pure study that I did during my master's, and those were my supervisors. Next slide. Okay, so there's an increase in stroke burden in Kenya, in Africa, and all over the world. And because the burden is very high, this has led to poor quality of life, and therefore we need to come in and manage that quality of life in order to improve it. Next. What is the problem? What made me to come up with this topic? It's because I am a physiotherapist, and as physiotherapists, we normally manage everything whereby we try to restore function, but then again, when it comes to quality of life, we don't deal with that part. Why don't we deal with that part? It's because we lack evidence-based standardized outcome measures to assess the quality of life, because we all know that if you can't measure it, you can't change it, yeah? And again, the available standardized outcome measures which are here, they lack that context and language appropriate. Next. So stroke prevalence is estimated at 0.5% globally. And in high income countries, we have stroke deaths and dialysis at 1.6 and 21.5 million. In lower middle income countries, we have stroke deaths at 4.85 and dialysis at 91.4 million. And in Kenya, stroke death is at 6.03% and is the second cause of disability in the adults. Next. Now, the rising burden of stroke has led to the poor quality of life. And it's this poor quality of life that has incited the rehabilitation team to try and come up with standardized outcome measures that can be able to quantify that quality of life. Therefore, we can be able to know what to manage. So the standardized outcome measures that are concerned with quality of life are the patient-reported outcome measures, meaning those outcome measures are completed by a patient. So that means those outcome measures, the patient should be able to understand them well. Therefore, the language and also the context of the outcome measure need to be understood well. Next. So one of those clinical tools that is classified under the patient-reported outcome measure is the stroke-specific quality of life scale. Now, the stroke-specific quality of life scale is a scale that assesses the quality of life post-stroke. Next. So, because this scale is supposed to assess the quality of life, unfortunately, this is not our scale. This is a scale that was devised in Europe, and therefore we cannot use it as it is, because the language and also the content in it is not appropriate to our Kenyan patients. And that's why we need to adapt it so that at least when a patient is trying to use it, he's able to understand the language. Next. And then why Swahili? Yes, we are adapting to ensure that the language is easily understood, but why Swahili? The reason why we are translating it to Swahili is to ensure that all patients are well catered for, because stroke does not only affect patients who have who are literate in English, but it affects everyone. And because Swahili is our official language, so that's why we thought it's good we make it in a language whereby every patient can be able to understand and use it to report about their quality of life. Next. So the broad objective was to produce a Swahili version of the stroke-specific quality of life scale. And the objective number one was first to translate it from the original English version to the Swahili version. And after translating, then we will adapt it to fit our context. Next. So the methodology, it used a very unique methodology, that is translation and cross-cultural adaptation. Now that methodology is a guideline that has been developed by the American orthopedic doctors, and it has 5 processes, whereby the first step is you do a forward translation, whereby you're using 2 Swahili linguists, and then you do synthesis, and then you do a back translation, meaning we translated it back to English to check if the words were still having the same meaning as they were. And then from there, we did an expert review committee. Now, these are the people who looked at the document and checked if the words are as they were used in English. And again, they looked at those words if they are our everyday language. And then finally, we did a pre-validation, and that pre-validation is the one that now comprised of 36 people from the stroke, with stroke, from the Stroke Association of Kenya. Next. So findings of the translation process. So as the expert committee were looking into those documents after it had been translated, they realized that some words and phrases were not contextually appropriate. And therefore, they relooked into those words, they adapted them so that they could be able to fit our everyday English. For example, there was a phrase that was talking about, I am not interested in food. That is from the English European version, which was meant for the European subjects. But when you look at that phrase in Kenya, we don't talk about I am interested in food. We talk about I don't have appetite. So if you translate that into Swahili, it talks of sina hamu ya kula. Sio eti sitaki kukula chakula, ni vile tu sina hamu ya hiyo chakula. Next slide. So the conclusion, after the expert committee looked into that, and after the pre-validation was done, the original English stroke-specific quality of life scale was translated and adapted to Swahili. So the study implication, a culturally appropriate Swahili version of the stroke-specific quality of life scale was produced, and the Swahili has the potential to be a useful outcome measure for use in Swahili-speaking patients with stroke. The last slide, recommendations. Because in physiotherapy, we use these standardized outcome measures to assess the progress and also the quality of life of our patients. And This is one of the tools that we are using, but it's in English version. So our recommendation is that if this tool can be used in our curriculum, so that now we can be able to use it everywhere. Thank you very much.
Thank you, Emily, for that presentation. At this point in time, we have one more presenter from online, all the way from Malawi. So I'm waiting for the presenter to come on board. And if you have questions, please push them on to the presenters. Just write them down in the interest of time so they can keep on thinking about them, so that when we come to the questions to be answered, then it will be ready. The answers will come out ready. So our online presenter is Wins. Wins, are you there? Wins Gondwe, can you hear us? Wins, can you hear? Please unmute. You're talking on mute. We can't hear you.
All right.
Okay, I understand that it is a recording, so I'll just introduce the topic. And the topic is understanding the association of Then's and Main's 3-delay model of care and maternal deaths at Magochi District Hospital in Malawi by Waynes Gondwe. So again, please put your questions, write your questions down. The online audience, please put the questions on the Q&A and not on the chat. Thank you.
I'm representing a micro-research project, and I'm presenting on the research title, Understanding the Association of Thaddeus and the Main's 3-delay model of care and maternal deaths at Mangochi District Hospital, Malawi. Background. Maternal deaths are a global concern, as we all know, but the burden is huge in low and middle income countries, including Malawi. Mangochi District Hospital in rural southern Malawi continues to experience high maternal mortality rates despite implementing national safe motherhood guidelines, which are implemented throughout the country. From 2016 to 2021, Mangochi has recorded between 30 and 58 maternal deaths. During the same period, 5 neighboring districts have registered between 2 and 13 MDs. So the 2 questions that we need to answer are, what specifically causes maternal deaths at Mangochi District Hospital, despite all the efforts? What are the contributing factors to the occurrence of MDs at the hospital? This gap necessitated the need to conduct this study for deeper understanding of MDs at the hospital in order to guide identification of specific issues that the hospital may need to address to reduce MDs. The 3 delays model of maternal care developed by Tedeas and Main is used to explain the causal relationship of MDs in this study. Delay 1, which is delay in deciding to seek care, occurs due to factors such as low awareness of pregnancy complications, financial constraints, cultural beliefs, and previous negative experiences with healthcare. Delay 2, which is delay in reaching a health facility, occurs when challenges like long distances, poor transportation infrastructure, and geographical barriers prevent women from accessing medical care in time. Delay 3, which is delay in receiving adequate care at the facility, where once a woman reaches the facility may face challenges such as shortage of medical supplies, inadequate trained staff, and insufficient referral systems. Inadequate trained staff doesn't mean that they are not qualified from their generic training programs. No, but they qualify. However, they need to keep on updating their skills as they proceed with their work, the in-service training, that is. The broad objective for this study was to investigate the causes, contributing factors, and associated factors of maternal deaths in Mangochi District Hospital. Specific objectives: 1, to identify the main causes of maternal deaths at the hospital, to determine the contributing factors of maternal deaths at the hospital, to determine the association of delay 1, delay 2, and delay 3 of the 3 delays model of care and maternal deaths. The study design: this study was a quantitative, retrospective case control study design, and we analyzed 33 MDs cases. These were all the MDs that occurred in 2022, and were matched with 99 maternal near misses. Those who experienced controls, they nearly died, but they did not. Still in the same year, 2022. We used a standardized data collection tool to extract data from cases and controls, which the data is normally kept by the Maternal Death Surveillance and Response Committee, which reviews each and every maternal death as it occurs. So the matching was done on a ratio of 1 case to 3 controls to increase validity and reliability of the collected information. The cases and the controls were matched by traditional authority and period of occurrence in terms of quarters of the year. Extracted data was analyzed at 3 levels: univalent, bivalent, and multivariate level of analysis. The results from univalent analysis revealed that majority of women were young. They were below 20 years, and being young, they were also primigravidas, they were uneducated, they delivered by cesarean sections probably because they experienced a lot of complications. They died within 12 hours of admission from causes of hypertensive disorders like preeclampsia and eclampsia and postpartum hemorrhage. Bivalent analysis revealed that young age and young gravidity were associated with the maternal deaths. That's the p-value of less than 0.05. All delays contributed to maternal deaths in this study at the hospital. However, delay type 3 contributed the most, and the causes for delay type 3 in this study were incomplete initial assessment by the health worker, inadequate monitoring of the women when they were admitted at the hospital. So they continued maybe experiencing complications. They were monitored, but action was delayed to be taken. Shortage of essential resources. In this case, mainly it was obstetric drugs, which accounted for 15%, and the common one is the MAXAF, which is used to control hypertension. Multivariate analysis revealed that young age and young gravidity were also associated with MDs. Women with DRE 1, DRE 2, and DRE 3 had 4, 5 times chances of dying, respectively, with a p-value of less than 0.05, than those who did not experience any delay at all, suggesting that timely access to maternal health care is critical in preventing maternal deaths across all the 3 delays. So overall, the findings reveal that women experiencing any delay at any level had 6 times chances of dying than those who did not experience any delay, confirming the fact that the cumulative impact of delay in maternal health care and that every minute counts. So we need to really address all the bottlenecks that occur at every stage of care so that we prevent MDs. So what are the implications for service delivery? Continued occurrence of MDs at this hospital, Mangochi, this hospital in 2022, despite all the efforts of safe motherhood, implies that the hospital should reinforce regular professional development trainings and mentorship programs to ensure that its staff are up to date with emergency obstetric care. And this reinforcement should include thorough assessments, treatments and care, and monitoring of women throughout the peripartum period. Additionally, Mangochi District Hospital should strive to ensure adequate supply of essential resources like obstetric drugs at all times by improving procurement processes and stock management. Furthermore, the hospital management should intensify supervision of maternal health services at the hospital as well as the whole district to ensure that maternal health care delivery from pregnancy through delivery is optimal, because some of the causes were from DRE 1 and DRE 2, not necessarily the hospital alone. These were the references for our presentation, and those are the people we acknowledge to have supported us. And thank you very much all for your attention.
Great presentation there from Waynes all the way from Malawi. So we have had 4 presentations. So I want to ask all the presenters, please, to take the high seats. You already have your questions. I don't know whether we have any questions online. If there are, we can also have them. We are going to give you each 2 minutes. I hope you have processed your questions. So we have our 3 presenters. We have Waynes online. Waynes, please check your audio if you are audible so that the questions can be relayed to you so that you can answer them. So I'm going to give you each 2 minutes. That's 120 seconds, no more than that. So that after this, we break for tea in readiness for the next session. So I'll start with Emily. Sorry, I'll start with Achieng. You are the first presenter. You have your questions.
Okay, I have several questions. I'll do the best with the time I have. First question, why do prescribers major in ceftriaxone than other drugs? So yes, this is noted in Kisumu County Referral Hospital, but in other facilities as well of that level, you find that ceftriaxone is the most prescribed antimicrobial in the inpatient. I will answer this question as a pharmacist. The reason is marketing. So the people who introduced ceftriaxone into the Kenyan market were very aggressive in their marketing, and the prescribers bought into it. And subsequently, as more, let's say, students get into these facilities, they learn that ceftriaxone is what we usually use. So they just continue with the trend. but this is a marketing issue, okay? So it's not really that the guidelines say that ceftriaxone is what should be used first. A related question, someone was asking about access to first-line antimicrobials in the chemist without prescription. Maybe this is an opportunity for further research. Yes, this is another big issue and another major contributor of antimicrobial resistance. However, it was not within the scope of this study. But yeah, again, this is a societal issue. It has to do with corruption and our moral fabric as a society. And yes, in other jurisdictions, all antimicrobials are issued on prescription, whether they are accessed, whether they are watched, whether they are reserved. But so this is a corruption issue that we need to look at as a society. Another question is on healthcare workers have knowledge on antimicrobial resistance and antimicrobial stewardship, but they do not implement, that the implementation and practice has issues. It is true, again, most of us here have heard of antimicrobial resistance. Most of our health workers have heard of this. How best would we ensure that healthcare workers use the AMS interventions? The best way is to come up with hospital-specific guidelines. But before we go to the hospital-specific guidelines, we have to get data. So that is why we do this PPS. We also use other tools like outpatient prescription audits and other tools. So once we get data, the other way is to collaborate between the healthcare workers, the different cadres, not working in silos. Yeah? So once you have the data, you can collaborate as consultants, as the pharmacist, and as also the laboratory scientists, and come up with guidelines for use. I'll give an example with this particular facility. We came up with a guideline for use of reserve antibiotic, particularly meropenem. And in agreement, all the cadres agreed that before we go to time, before you use meropenem, before you prescribe meropenem, you must have culture and sensitivity results. And without the culture and sensitivity results, it would not be issued. And that is how we manage the use of meropenem in that facility. Okay, the other is, how does excretion of antimicrobials in urine and stool have to do with resistance? Your microorganisms are in the environment, you're exposing them to antimicrobials in limited amounts. So those antimicrobials will not kill them, but the exposure will allow the microorganisms to develop tactics of evading them, to resist, okay? The last one is on, is data collected for 1 day generalizable for that facility? No, it is not enough data, but it is a starting point. It's better than having no data at all. And lastly, someone was asking, this is a referral hospital. So patients in that hospital may have used access antimicrobials in the lower health facilities. So he's asking, is this really inconsistent with the guidelines? We can argue that way, but we know that particularly at that time in 2023, patients, the referral system was not very straightforward. People would just come to the referral hospital even though they have not been referred. So maybe with the issue of the SHA and SHIF, maybe we'll have a proper referral system. So we can't say that everyone who was in that facility was referred and had previously used an access antimicrobial. Okay, so that's beyond the scope of the study, but we can do more research on that. Thank you.
Thank you. I tried to answer some of the questions which arose, and there are many. That means the topic was interesting. One was asking, can we replace the epidural analgesia with oxytocin? because of the concern of addiction. One, oxytocin, we use it to augment labor. More contraction, the labor intensity increases, and I'm here advocating for painless labor. So in epidural, basically we use an anesthetic agent, and then we combine it with an opioid analgesia, most of the time bupivacaine and fentanyl. So the issue of addiction, because we are using at the duration of labor, normal labor takes the maximum 18, but use of epidural has shown that the duration of labor shortens. So exposure to these drugs, again, cannot lead to chances of it causing addiction are minimal. And then if there is another contradiction of the analgesia, then we opt for other methods of managing labor, which are there. We have other methods. And then is it expensive? Is it covered by SHIV? So those are some of the limitations of its use. I've looked across Nairobi Hospital and Aga Khan, which offer that. And their package was at 40,000 for those who are opting. So for a common mother, it can be expensive. It is not covered in our SHIV. But we have recommended that it is made a standard option for practice. So if the policymakers do that, then SHIV can now cover it. And then what are the standard pain management? So in labor, and did you compare with the epidural? So we have traditional pharmacological and non-pharmacological ways of managing labor pain. But again, we have a cultural attitude towards labor pain where we believe that we have to kanungo. Lazima, in order to give birth, you have to feel the water, the pain. And most of in a public hospital, that's where now you are told back water, massage, or you are given NSAIDs which are not effective in controlling the pain. So that's why we are here. We have advanced, and we have these ones which are more effective. So let's use them and give option to those mothers. As we are waiting for it to be affordable, we can give it to those mothers who can afford, so that they can improve their labor experience. Did I compare? No, because that was not the scope of my study, but comparisons have been done across, even with the other ways of this analgesia, how is it offered? We have compared with other traditional methods I've talked about, and we have seen this one is more So most births in developing countries still take place at home by untrained midwives in developing. How can labor management using epidural be made more accessible? In developing world, I've seen home births, but are they? I feel like the midwives there, they are a bit trained. And those home baths, or the home baths, there are some ways they use to control the pain, and they do water baths. The hydrotherapy is believed to also minimize the pain. So the epidural at home is unlikely because of the complication. So you need resources, oxygen to monitor and manage the complication. So accessibility is about training and increasing resources. Okay, thank you. Why Kericho? I said in Kenya, this practice is confined to tertiary hospital where Kericho falls because of the resources which are required to monitor the procedure. We need trained the anesthetists. The anesthetists are the ones who offer the epidural. So you cannot find them in maybe in a health dispensary. So that's why. And then someone had issue about the study design. It is a quasi, it is not a true experiment. That's why there were no controls. And in a quasi, you can use one group to do a pre-test and a post-test. And can we do nurse anesthetist? Yes. In KMTC, also KISI KMTC, we train the nurse anesthetist and also the clinical medicine anesthetist so that we can also pool the professions who can administer the analgesic. Thank you.
Okay, thank you. I have two questions. Number one, are you able to use the available software for translation? Yes, there are so many available softwares for translation, but most of them, they do a direct translation, and we were not interested with direct translation. We were interested with having our everyday Swahili words, so that if I take this document to Coast Region, the Swahili people will be able to understand it the same way the Swahili speakers in Nairobi and Kisii and Kisumu will be able to understand it. So they are there, but we were not interested with direct translation. Question number 2. Is there a role of artificial intelligence, digital translation of the scale? Yeah, of course, AI is the way to go. There's a very big role, but during that time when I was doing this, I was not able to get the right AI to use. But then again, yesterday when we went through the AI, I was able to check well, and actually there are softwares in AI, and I'll reconsider using them because this is the way to go in translating tools to our context. The Swahili version is there, is online. You can download it and you can use it anytime you want. Thank you so much.
We're waiting for Wayne's. I don't know whether he has the questions. She has the questions online. Wayne's? Have the questions been relayed to her? Okay, it's okay. So I think then in the interest of time, we want to conclude this session. If there were questions for Wins, she's still going to answer them. So please put your questions to her. And if you have questions for this group, also give them, sit with them down. They have done a good job. They have done their research. They have come to present. They have presented a very good results and even way forward. So can we give them a loud of applause? Well done. So at this point in time, I want us to break for strictly 30 minutes. Okay, I'm told 30 minutes is too long. So 15 minutes strictly, and then we'll be back after 15 minutes for the next session. It will start promptly after 15 minutes. So let's get moving. 11 o'clock sharp, we start.
Any specific reason as to why necessary use that?
those of us out in the foyer, let's make our way in. Kindly, let's make our way in so that we can begin the next session.
Yeah, the one who put the numbers, they're the ones who have not done. We will find out because they're the ones who have not done all of them. This one gave an excuse. She might not have. Let me just do the announcement and come up. Okay, I think we are ready to start. And so let's settle down. Those of us who are still out, kindly come in. We settle down, we start. Before I hand over to the chair of the session, I wish to announce that the following kindly come and occupy the front seats if you're in. Rachel Ireri, Rachel, please come and sit on this front seat. Caroline Kimani, if you're in. Carol Kimani, I can see you coming in. Kindly come and occupy this seat. Francis did it yesterday. Joseph Mwangi, and Keisha Mendez. So those four, please come and occupy the front seats so that we can now start our session this mid-morning. Let me invite the chair of the session, Dr. John Aswani, to take it up from here. Karibu.
Thank you. I believe this is the second last session of our conference. And like I said at the beginning, we, as a committee, try to look at aspects of clear interest to our delegates and ourselves. We know that the area of mental health is key, is critical. But within that same area, there are some players who sometimes can get lost and missed out. I came from a home state where my mother was a potter. And as the saying goes, in the home of the potter, you only have the broken ones, but the good ones are for sale. In the same way, many of us in the health sector can become, we can suffer from an element of occupational hazard where we get lost and we do not benefit from the care we need. And so this morning we are privileged to have Dr. Susan Wambui Getao to look at this space of mental health, particularly among the health workers. What are the issues and how do we get help before we can be at a place where we can help others? Dr. Getao is a lecturer and a clinical practice director, counseling at African Nazarene University here in Kenya. She's a licensed level 6 practitioner in counseling and a psychologist at that. And she has participated in many areas. She's an accredited senior counselor supervisor and chairperson Kiambu County. She is a counseling psychologist consultant in various government and non-governmental organizations. Specifically, she has also gotten accreditation to mindful self-compassion training from the USA. And that's what we want to tap into. She's a founder trustee of the Susan Getao Counseling Foundation. She's a trauma counseling expert and also has offered volunteer counseling services to the Kenya Defense Forces and Soldiers of Peace International. She's a member of the East African Standby Force and also a national awardee of the Presidential Award Mashujaa Day of 2018 for her humanitarian service and academic achievements. She is equally a media consultant on social and mental health issues and an award winner of the best online course developer in counseling practicum, South Korea in 2023. But above all, she's a researcher and an author. And so welcome, Dr. Getao, to take us through this area. Thank you.
Thank you. Thank you, Chair of the session. And all protocols observed. Good morning. And thank you for having me. It's a great honor to be here. I think I take medics very seriously. And I am one of the counseling psychologists that fought very hard for the counselors and psychologists board to be in Kenya and fought a lot so that we can be under the health ministry, because mental health is part of the health you talk about. I was asking myself, 30 minutes to deliver. There is no presentation, it's only me. So you can concentrate on looking at me, and the online ones can look at that. So I do have slides for this presentation, but I also thought where we have reached, we need competence-based approach to everything. And so I said, I'm gonna take this practically. And whenever you hear of the carer, the frontliners are actually people in medical healthcare. Because every day we are getting sick, every day we are giving birth. In fact, if that works, I might go back and get more babies. You call it an analgesia. Hey, I'm telling you your terms. I hope my students are also not floating. We have Caleb here because there's something you are doing at KMTC that I think Kenya needs to also embrace. And those of us watching us, listening to us can actually support your cause. Caleb, you can stand and wave. Yes. Caleb Woodworth is from our sister university in Ohio, Mount Vernon Nazarene University. He's here for an internship practicum exchange. Funded by who? By the university, and partially for him, if he wants to go to Masai Mara, that's his. But you can imagine when they come to this country and they learn and they do even the micro research you have talked about. When they go back to their country, the promotions you have mentioned about one of the students and all that, they really get it because you have done it. So I pray that KMTC, you will have more people to bless you, more organizations to bless you, because there are so many health challenges that actually need evidence-based interventions. So Caleb, welcome. This is how we welcome people. Food, a lot of food and all that. And that is also one way of caring for the carer. Anyway, do you guys get stressed? A lot. Do you guys get burnout? Do you guys get traumatized? Do you guys get compassion fatigue? Yes. Oh, the students not it. Those ones, I think it's just stress because of assignments, Is it? But they are looking at me. You know, one of my interns, Vivian here, lost a friend of hers who was doing medicine. And when I talk like this, it comes from my heart. We counseling psychologists are very open people, very open and truthful, because I think our learning, teaching institutions have also become very good breeding grounds for stress, burnout, compassion fatigue, and vicarious trauma. And it can come from many quarters. But just like we are trying to make women give birth with least or no labor pain, we can also make our learning, easy. I'm looking at how Caleb is being followed by his supervisor. How is he doing? Is he acclimatizing with Githeri? Sometimes I wonder when these students come, the orientation, are they prepared that they will actually come across or encounter a lot of stress along the way? Thank you. Thank you, Dr. B, for saying no, they are not. Because part of that orientation, we don't need to lose them. How much does it cost to train a doctor in this country? It's a lot. Do you even have an estimate? We should even have that estimate. Such that the minute we lose a student who is in a medical school, the minute we even lose that trainer, that lecturer, we have lost for this country. A very sad case happens at Moi Teaching and Referral Hospital. If you can recall the year, I may not recall it now, but we lost a doctor because she was murdered by her. Very good. And I want to tell you, I knew that girl from the age of 3 years. And I knew the effort the mother had made. I knew the effort the community had made. But because of such things I am talking about, because it was not a murder by another, and a lecturer, it was just by another what? Age mate. We have seen KMTC students. In fact, I was brought one. We tried fighting to bring him back. It was hard. But nobody was understanding beneath the alcohol and drug substance abuse, what else? We call it the in-between. And so as I am talking to the faculty, as I am talking to Kenyans who could be watching us and others outside Kenya, I want you to know the mental health burden is real. And because your biggest mentor is World Health Organization, in 2019, May 2019, World Health Organization declared burnout a serious mental health condition as much as it is a serious medical condition. So if you go to ICD 11, you will see whether they've already put it there. We are yet to see it on our DSM-5. What does that mean? And in fact, the people they investigated were nurses. Those nurses that sometimes we take for granted. And it has now gone down to the CHVs, the community health care. I think you even have another term for them now. You keep promoting them. Eh? Yes, you keep promoting and changing terms, right? And us, we are not exempt. Why I said I want to make this very practical is because in 2020, KMTC was one of the causes of my very severe lower back pain. But that's how our friendship began. Because I was supporting the ones who were here, the ones who were receiving people from the airport. And the stories I was hearing also, because all of us were glued in our houses. And so for me, I was there. How is it, Grace? Hey, Victoria, how is it now? Hey, Felista, how is it? You know, and we became friends. And from that, they thought about the students. I hope the peer educators manual is implemented. I hope it is. Students, do you know about the peer educators manual? So that is how serious I am. We cannot be using such resources like Dr. Susan Gitau to develop such a powerful manual or resource, yeah, and we are not implementing. So I want to challenge the students. This faculty is so burdened with a lot. They have to think about such a conference. They have to think about feedback to the government. They have to think about issues that are in the community. So we need serious peer counselors and educators from the student family, that you can come out and say, a brother for a brother, a sister for a sister. I don't know how it feels if you started a journey with one student that you know even came from one of the most or remotest, there's a word like that, area of this country, and then they did not finish for one reason or another. In my university, some of our students pay school fees for their fellow students. Do you have such a kitty student to student? Because as I am talking about these mental health issues, I have realized in developing countries, you cannot just tell me have a good head here, have a smart head, and you're not feeding me, and you're not clothing me. And for a medic student to actually make it through, is it easy to get through KMTC? No. And that is why I was listening even to the faculty, and you can tell the difference. Even when I interacted with you for the period we were developing the peer educators counselors manual, you are not like any other professional. There's seriousness, either because you know you're dealing with life. You're the first contact with life. And so I pray that our students who can even volunteer, I don't mind. I don't live very far from here. I live in Thika, right? And there are those ones who really want to implement it, because I know sometimes how busy you are. I guess we used a lot of money to develop that. At one point, we were in Kisumu, we went to Taveta, some of it we've done online, and we have a very simplified document for these young ones. I want to tell you, it really hurts me to lose students. And when I also look at the faculty, I know what you go through. Right now, following COVID-19 pandemic, majority of faculty members anywhere, whether it is in an institution like this one or where I am, it's not easy. It's not easy. For the first time, I have taught 5-6 units in a semester. And I always say, if African Nazarene University didn't have a very good learning management system, I don't know what we would be doing, because I prepare materials in advance. And that's how I won that award. Because I was like, when I'm not here with the students, how can they navigate practicum? So I had to create an online class, but with some motivation. That motivation is good. You buy a good laptop or you install some features that can help you. So I think when I look at you and I'm like, you're really trying, to be very sincere, Chair. You're really trying, and my prayer is that you will be heard right and things can flow better, because it took one voice for me to say during COVID-19 pandemic, and one of your faculty members took it seriously, and we went ahead and said, not just us, how about our students? And I pray that we do well. Now, do you know the difference between stress, burnout, compassion fatigue, and vicarious trauma? Yes, you do, eh? But maybe in a nutshell, we all get stressed, right? But when we talk about compassion fatigue, when you talk about burnout, it is work related. So you can imagine you getting sick because of your work and your engagement, including the student's academic engagement. And how do you know you have burnout? Burnout simply means punda amechoka. Punda akichoka anafanyanga nini? When the donkey is totally exhausted. We are the donkeys here. Let's assume we have reached that point. We are totally exhausted. What do? Yeah? You never show up. Some people will never show up on duty, right? What else? Others will sleep in and realize time has gone, right? What else? You are totally exhausted. You know, you have to know yourself. What else? You lack interest. Can you imagine the way I love counseling? The way I also love telling people stuff on media. And then I'm like, no, KTN, don't call me. Citizen, don't call me. No, don't shakahola me. You know? You can imagine, and people need you. Some people resign. How many of you have you ever returned back? Tafadhali, just to go home, wait a little bit, and rethink the decision. Me, I have resigned twice, but never resigning fully. And I resigned once because of burnout, but I was not this knowledgeable. I used to work for the government of Kenya under the Teacher Service Commission. I have taught for 5 years in high school, and I have taught for 7 years in a teacher training college. But how did I resign? I started my PhD. I was going through a very tough period in my family, very tough. You know, where are those things you don't want to tell anybody, right? Yeah. And then here, the college was asking, she has finished her master's. It's not even related to this teacher training college. She has finished, she's now doing her PhD. So I was one time asked, how is it related? Hey, it's so basic what we study here. That is how shallow sometimes we think, and we block others from what we call career, growth, and development. So I was torn between living and staying. Leaving my PhD studies or just staying. I decided to pursue my PhD. And I did. Thank God here. Do you hold students because they have not finished their research projects? For how long? You see the way you are talking nicely. For how long? 1 year. I'm telling you, students, that's why this is for you. This is for you. Whenever you hear any research presentations, anywhere, even if it's mini, please go, because that's it. And I am a very good example. I may not talk about that story today, right? And when I look at my country, when I hear research, I vibrate. But I ask myself, which research do you do without funds? Which one? Serious? Hakuna. So I don't know how much money you receive also KMTC for your research kitty. Because you keep talking about underdevelopment, keep talking about developed countries, developing countries. Where is Kenya, by the way? And where is KMTC? You're also developing. You're work in progress. You're low income. And you know, you cannot argue from Nowhere. You cannot even ask for money from nowhere. What makes our students delay in their research project? What makes them delay? Money. To be very, look at Caleb here. The supervisor last night writes me a very good email and tells me, thank you for supporting Caleb in his research project. I am willing to do anything from the university to ensure that his project is high quality. We want to hear that from KMTC. We want to hear that from the Ministry of Health. We want to hear good things. Now, the other thing I want to ask you is compassion fatigue. The person who gets compassion fatigue is that worker who cares for another in distress. So are patients happy people? Yes? Are our students happy people, faculty? Not always. There are times you can tell this student is struggling with something, not about academia, what we call external factors. And you're like, he's a very brilliant student. What do I do? You also get compassion fatigue because you are trying to fight for them. Oh, please, hata akilewa hivyo sana wachana naye, hata akipigana hiyo vita yote wachana naye, nitasongana naye. You're saying, even if they fight, even if they are drowning in alcoholism, leave them alone. I am with them, but they don't change. You finally get tired. So anyone working with human force that is sapping energy from you, you are actually a very good candidate of compassion fatigue. People who mean well in any venture, in any project, and you don't break through, you are a very good candidate for compassion fatigue. And when you get it, the serious thing is that the same things you tell us to take care of, now you get affected. You can imagine a medic who is complaining of headaches 24/7. You can imagine a medic because you are a concoction of physiotherapists. Muko wengi huku, sindio? Then someone is complaining of what? Gastrointestinal complications. Another one is complaining of eyesight. Another one is complaining of muscle aches. Another one is telling you, these days I sleep in my bedroom and my wife sleeps in her own bedroom. You know what I mean? Because other things are not working. Yeah? We have someone who tells you, where I am right now, I don't think I want to tolerate even the smallest nonsense. They will know who I am. Can you imagine when you start talking like that? And you think those guys are okay? They are not okay. So I want you to think about yourself physically. How do you know as a person you are stressed, you are fatigued physically? Because all of us are uniquely wired. So how many people is headaches? Headache people, where are you? Imagine this is also research. Headaches. And headache, it depends on where. Which part of your head? The frontal lobe. Imagine the thinking brain. So that person stops thinking. And so you find professor here behaving like one who has never gone to school, saying things that are not making sense, or hurling insults that nobody wants to hear. Others, it's here. Which part is this? You know, when I was in high school, they used to call it ati na ni uongo, hiyo si ni uongo, ati medulla oblongata. Lakini now when we talk about the tripartite brain, we talk about the brain what? Stem. It's dangerous, by the way. And I want to do a small exercise right now because I said I want to be practical. Can you sit upright? A small exercise right now. Sitting upright is your hands on your laps. You see now she has stood. Now, and you know this is practical. Mimi nimesema sit na daktari amesema simama. Kwa hivyo hii haina nini? Ungwana. Burnout, compassion, fatigue haina nini? Ungwana. Yes, there is no hero in this. And I have told you I was once down there, right? Your hands on your laps. Yes. Are the men there? Are the men there? Great. Now, it's just something I want to test. Our neck. You see the way you're ready to go to the next chair. So if I say right, so your hair is straight like this. So I say front ni kama askari, right? If I say turn your neck right, let it turn right kabisa. The way munaonanga guko kwa gwaride. Okay? Right? Put some little tension, eh? Right? Left? Right again? Left? Right? And left. Without tension, right? Una ease out, relax. Left, right, and left. And front. Ni gani poa? Without the same neck. With the tension, how was it? Wengine ni okay, that's level 1. At level? So I want us to go to level 2. You take your neck up completely and then down to the chest. Up, down to the chest, up with tension. Down, up, and down. And front, with ease, up, down, up, and down. Up again, and down, and front. Notice the difference. Notice the difference. Now we are going to that level. It is called cuckoo. It is called what? Cuckoo. Cuckoo is chicken. A live one. Eh? Yes, so I want you to tilt it. Nikisema, if I say cuckoo right, for those who don't understand Swahili online, cuckoo right, you go, whew. You see the way mother hen checks, guarding her chicks. Yes, and I'm looking at you, and I'm looking at the people short-changing my exercise. Let's go, cuckoo right, with tension. Even mine have had cuckoo left, cuckoo right, cuckoo left, cuckoo right, left, and front. Now with ease, right and left, right and left. One more time. Here we are. And front. I'm looking at our presenter there. Say, And I said, you should be at ease. 90 degrees sitting position. Daktari. Na mwingine hapa. See, there is no one in front. So you can, your legs apart, then on the ground. 90 degrees sitting position. Daktari, yes. And we are also used to sitting like that, but we don't know. We are even the ones who tell people, especially those patients with issues with blood pressure, right? Do you tell them, cross your legs? What do you tell them? And you know when you have burnout, compassion fatigue, if that time your BP is taken, you might be shocked. There is one time I went, because I was going to Tanzania during COVID period. And you know, they were not taking these things. So now I said, before I go, let me tell them I am okay. So I came to Lancet, right? But before I came to Lancet, I also went to see my doctor. And when they took the BP, they told me, do you know you can't even fly now? Hii BP yako iko juu. And you know, I had never had issues with. I was told you can't even live here. And that I thought I was walking right. You know, you can't leave the hospital. We are going to hold you here at least for 4 hours. You guys, you do that. Madaktari, which is okay. You save a life. And then I was told you'll take these pills for 2 weeks. Hey, and I started wondering, now me and blood pressure pills. What about when I get to 60? What will I be taking? All because of work. And I'm telling you, my life changed drastically. I really take care of myself. Level 1, level 2, level 3. Now level 4. That one I call it Indian. What I call it? Indian. Now, this one who gets it, you know they are good. Indian is done like this. Let me see. Oi. So you come here, the former chair. Come, the one there is you. Come. And I want one medic student who has done it well. Oh, another one there is chaos. Any student? You know, I see young people doing it very well. None. Yeah, let's try. Let's go, Indian. Oh. She's doing it very well. Just come, the lady in black. We clap for her also for telling us it is hard to do it, right? Yes, and by the way, it's part of what you guys teach. It is part of biology. Which vein is here? It's a very serious vein that is around here. Yes, at least I know at KMTC, I will have left one who can teach others. Yeah, let's go, Indian. You see, can you see the strategy she has used? She has used this one and now gotten it, until you're able to do that. But if you can, you try by doing this so that you learn, okay? The men are the most affected. Can we clap for ourselves? Why are the men most affected? That is researchable. Because they are the ones who have it rough to doing like this. Either because balancing the two sides of the brain is at all older for them, right? Yeah, they're either using what? Left or at some point using right. So balancing, and that is also part of stress. And even when I'm dealing with men, I know they are not the same as females, yeah? When I'm dealing with males. Now, if you can remember those 4 levels on a daily basis, it feels different. Are you feeling different? Who is feeling more inspired to continue with these presentations that is the last day? Yes. And I have actually used an exercise that takes care of one of the most powerful veins. But we don't use that exercise because maybe we don't know. Which vein is here? The vagus nervous vein. And if somebody wants to kill you instantly without pain, where can they hit you? Here? Even animals. If we want, and then we can slaughter. Meaning it's a very delicate but very precious vein. And currently we are doing a lot of research on what we call neuroscience or neuroplasticity as a way of easing our mental health challenges. And that is why when I also went to train in mindful self-compassion, the basic school is mindfulness. And Africans with our needs, when people meditate, what do we say? They are charming. When people stay silent, what do we say? They are planning evil. Right. When people practice yoga, what do we say? They are witches, you know? Yet, we Africans have been meditating since time immemorial. That is why in every community, especially in this Kenya, there was either a mountain or an animal or a river that was very what? Sacred. And what did we used to do, or what do we still do? We go there and do what? And wait for answers. And even right now, when Kenyans, we are trying to understand who we are. This is a time we are finding Kambas, we are finding, including these Gen Zs who don't know their mother tongue. In fact, is there a tribe 45th for the Gen Zs? There should be. Because these people, they know a few of their mother tongue words and they use with a lot of what? Pride. But we have a gap because of that. And that's why I see us losing them because we don't understand them. Could you tell your mother, Mommy, you are tired, go and sleep. And you know our mothers could even sleep near the fireplace. Ajiko, I have said if I open my eyes and I find you there, and she's there, not even moving. Did you even used to tell her anything? What about the Gen Zs? Isn't it that part of stress? The Gen Z goes and does what? Uses AI. because I am even telling parents, if you don't expose your child to technology, then prepare for them to be sidelined, so that we can start thinking of responsible AI, use of AI, use of technology, just like you said. Who is that presenting on the Swahili tool? Yeah, she's yes. Yeah, like Caleb here is actually translating a tool in his research into Swahili. So I read one of it, we were now laughing, and I said, this means this now, direct translation. So when you talked about the experts and all that, I was telling him, you're even benefiting from this very conference. This is an international conference for medics, and we are happy with your research, by the way. Now, that is physical. I haven't even finished. If I told you to stand up right now, because I don't have time, thank you, and I told you to knee your knees, just to go around with your knees, some of you would be. So kindly do what we call a body scan. Do a body scan from the crown of your head to the soles of your feet. And as we age above 50, what happens to our bodies? And what are we doing? For those who experience a lot of lower back pain, in the morning, the exercise is 5 to 10 minutes. You just do like it's press ups, but it's not press ups. You guys are good at press ups. We women, not very much, because we are blessed with a lot of blessings around here. So we do a little bit, but that turning a little bit like this, it helps this lower back pain. Any movement, even with your hands, lift up your hands, you see. Things we take like silly things, but they're very helpful. Both hands, lift up both hands. Go to your right. Don't go with me. My right is this. If you are not attentive, left, right, and left, right, and left, up, and down, up, and back, back. How does the back feel? Nice. And then you keep saying there are a lot of increased disability among the adults. And who is going to laugh at you if they find you also walking, knowing you're taking care of what? After all, they'll find you healthy in many. We no longer dance. I don't know. Do you have time for dancing for the students? They have very good music sound system. Oh my. Please, my sons and daughters, wanunuliwe nini. And salsa is very powerful. Any salsa dancers there? Students? Yes, that movement that you find people moving like that. Why? Yeah. And we have lots of these dances in Africa that are very therapeutic. Even when we went to Taveta for 2 weeks, there was no dancing. Only some walking, and we were told some people here can harm you. So where do you walk? If you're in a confined place, where do you walk? In your own house. And you don't just walk. Walk as you count, okay? Like 1. That's why you find confident people. People say they are what? They are proud. At the age, they are walking proudly. But you're taking care of yourself. Don't just walk. Don't just sit. You see, don't just sit. And I'm talking to medics. So for me, I know today it is home. Sitting, posture should be upright. Standing, upright. Even when you're talking to people, what were you saying? You're actually doing some damage to your spinal cord, right? And others as they walk. No, if God has blessed you with good health, walk upright. Now, when you talk about emotions, I always talk about the 5 main ones, the mothers and the fathers of others. Anger. When you are stressed, burnt out, having compassion fatigue, vicarious trauma, which one is yours? Do you have anger? Do you have fear? Do you have anxiety? Do you have hurt or sadness that is chronic? Do you have guilt? Which one is yours? And for people who have compassion fatigue, the number 1 is anxiety. followed by what? Anger, which comes out as irritability. And we want to excuses. I am easily irritated these days. Can you imagine? Even your face changes. Can you imagine the way I smile nicely here? And then I start turning to be that irritable woman. Eh? What can you happen? You even look ugly. So honestly speaking, just know yours, which one it is. Others start crying aimlessly with no reason. Do we have them among the medics? Yes. Someone who storms into your office crying. I'm telling you, I don't know. I think I'm in the wrong career. I'm in the wrong career. I think I chose the wrong course. That Mr. So-and-so. But if you know how to manage those emotions on a day-to-day basis, then we do have the social aspect. Some withdraw, some talk more, some connect more. You know, he's telling me, you know, you spent 15 minutes giving my bio. So, so I'm taking my 15 minutes, yeah? And because you need this. So if you look at your physical, you look at your emotional, your cognitive. Cognitive is when you start messing up even in your workplace. The content delivery, preparation, memory, concentration, attention starts fading. And the worst, you become very negative. Ati hiyo ni KMTC conference ya nini? Waende wale wanaenda. Huyo mtu ako on the road to depression. Because depression, I summarize it from my experience and even from Beck, that you are negative about yourself, negative about others, and negative about everything else. Then we know you're on the road. But could it be that person has compassion fatigue, has burnout, and we do not understand? There are also people when they get that level of unproductivity because here is not working. They come to disturb others, whether it is in the lecture rooms or in offices. And you're like, you're very seriously trying to meet your deadlines. I think, well, sikiza kwanza, hii kazi si yako. Hata ukienda leo, there'll be others to do it. If it's the students, they are told there is no award of being the best medical student, you know. So it's good to know where are we and where am I? Socially, are you connecting? Because a normal human being with human face connects with everyone, including children. But could you have gotten there because of what we are talking about? When I also talk about the spiritual component, and I'm not talking about religion here, do you have meaning? Do you have meaning? Have you made meaning? Do you find purpose in what you do? There are some of you, faculty, you've been here since day one. You've been here in the planning, and you will see this closing ceremony of this conference. What is driving you? Is it money? Is it because you want to see change? And I want to tell you, the people who leave legacy are not rich people. Last year, I was shy from mentioning that foundation I began in memory of my father, who had his own issues from his family, then coupled with burnout, and then depression, and then because trauma has gained kind of attention after DSM-5, after DSM-5 manual came out in 2013, because it was removed. Post-traumatic stress disorder was removed among other anxiety disorders and set separately. And because of that, I want to tell you, my father had nothing else but PTSD. Chronic PTSD, multiple PTSD, that I can talk about his story. And I told God I want to actually start a foundation so that I can create awareness with what I have. And the biggest resource that I have in this nation is me. So anytime I appear on TV, and I like to say it openly, it's not that I get paid, but I know I'll save a life somewhere. I know I will educate somebody somewhere. And I want to tell you as medics, the oath that, because especially for the students, you guys are training them. Those ones are going to work, most of them. Save a life is your first calling, right? Who remembers the case of baby Travis? Do you remember the boy who was forked by the brother? I have worked with those kids up to now. I have worked with that family up to now. Do you think that family can pay me? They can even take from me. I want to tell you, and I have never lacked, and I will never lack. So I want to empower you because I see Gen Zs showing us how they are what? Patriotic, and I'm giving you a challenge. And start now while you're still a student. What is it that you're doing to another human being who is lesser than you with what you have? When I was a student at UON, I was coming to this Kenyatta National Hospital, the cancer ward for kids. And I would feel the pain if I came next month and I was told so-and-so died. But that gave me meaning for life. My father's mental illness gave me meaning for life. My burnout recently gave me meaning for life. And that's why if you call me any day, anytime to talk about care for the carer, I'll come. This is just but an appetizer. And because of time, I know the other presenters are looking at me and say, wait, don't take everything. Can you sit upright? I leave you with something that you will never forget. Day in, day out. I've given you one tool or resource of Vegas nerve what? Exercise, neck exercise. Very powerful. Even for the students who get bored in class or you feel like you're totally tired and you can't hold it. The other one I have given you is what? The posture. Small physical exercises that look silly, including holding your fist like this and releasing it. Simple things, right? Tapping your face. Can you tap your face with your fingers? 2 fingers. You know, I have the mic. I mean 2 hands. Use your 2 hands. Just tap, 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 tap. Tap the forehead. Go to the eye bone. Thank you. Go to the ear. Go to the side of the ear. Those who don't have specs, go to the nose here on the side. On the side of the nose. Wale wako na nini kama mimi hawaendi hapo. Naona wengi mko na specs, eh? Go to this part of your mouth. What do you call this? This part? It's the lip. In the lip, upper lip. Go to the lower lip. Okay? You're just tapping. Tapping. It looks silly. Some people can go superstitious, but that is your body. How are you feeling? And if you go online, there is that tapping therapy, okay? Even feet, okay? Even feet. If I told you to stand right now, we are the Homo sapiens. But where did we start? Homo erectus, eh? If you tell a human being to stand on their toes, it's better. Tell them to stand on your heel. Even me, they will fall. But if you keep doing this exercise, by the way, it is very powerful, eh? Especially for what? The back and for your spine. Now, all of us, Chinese, Americans, Africans, God gave us one common gift. We cannot say you have more than us. We all have it. Which one is that? Eh? The what? Yeah? The thinking. All right, that one has levels. It has levels, but the breath of life. So can you sit upright as I leave you with the breath of life? It's not mine, it's God, but I'm showing you how to use it. Sit upright. Are you there? Okay, just trust the process. Close your eyes. And I would like you to breathe in through the nostril. And I'm going to count for you so that you can rate yourself with that ability or resilience. So let's go breathe in. 1 and 2 and 3. Hold it. 1, 2, and 3. Release it through the mouth slowly. 1, 2, and 3. That's just one. If you open your eyes, just know you're very anxious. If you keep them closed, as I have instructed, just know you're doing better. Let's go. Level 2, breathe in. And 1, 2, and 3. Hold your breath. 1, 2, and 3. Release it. 1, 2, and 3. I can hear some people struggling. But the more you do it, the more you stabilize your breath, the calmer you become. Level 3. Breathe in. 1, 2, and 3. Hold it. 1, 2, and 3. Release slowly. 1, 2, and 3. Keep your eyes closed. Let's do one wrap up of a deep one and out. Let's go. Breathe in and out. As you're seated there with your eyes closed, how often do you take time alone? How often do you check on your breathing? By simply placing your hand where your heart is. You can do it right now. Place your hand over your heart. How many people do we lose in our countries, especially the sub-Saharan region, of heart attack, cardiac arrest, and especially very resourceful people from all walks of life and professions? How many people have developed very serious medical and mental health conditions because they do not do daily self-care? How many people have acquired so much, but soon after retirement, they disappear from the face of the earth? Or they spend so much money with medical care. We who are here this very moment, can we make a vow to care for ourselves? Because we may look for an external carer. They may never be found, maybe because they don't understand, they don't know. As a student, as faculty, as sponsors, as managers, as leaders, we need self-care, holistic self-care, spiritual, social, cognitive, emotional, physical, and behavioral. If I am doing something and it's not working for me, I don't need to do it. May you know there is power in silence. May you know there is power in the breath of life. Thank you, and God bless you, and God keep you. Thank you.
I do not know what to add. Yes, burnout, stress, vicarious trauma, those are things that would face us every day. Important that we are able to identify when in that space, and we have been given options of what we can do in the context of self-care. I think that is my take home. We'll welcome I think if there's one or two burning questions, and then I will request Dr. B to appreciate our speaker. Just any question from online, any question? All right. Appreciation from our online audience. You have a question? A comment? All right. One comment.
So my name is Damila Poda from Gatudu KMTC campus. I'm so honored to be sitting at this conference and learning a lot from you, Madam Susan. I'm so glad because you have reminded me of when I started in KMTC about psychology. I've really learned a lot, and I promise you I'm going to be the stay about psychology because it's really affecting the people in the community. God bless.
Thank you so much, Dr. Gitau, for that powerful presentation. We are really blessed to have you. My name is Chas from Boni campus, and I have two questions. The first one, in the recent past, we have seen a lot of mental health cases, especially with young people. And most of the cases are work-related. So my question is, currently in the country, do we have policies or guidelines which promote inclusion of psychological services in the workplace? And secondly, now that you've said you've contributed so much, especially in the field of counseling and inclusion of that profession under the Ministry of Health. We've noted most of the counties, which are the employers, we have psychological counselors and psychologists working there. And one worrying issue is that they are not equally remunerated, especially when we talk about the allowances which other healthcare providers get. So are they part of the health workforce? Because again, I feel they may be experiencing that that issue of exclusion, and it may have a toll in their mental health as well. Thank you.
Yes. Thank you. Thank you. Yeah. And for that student, make sure we have your number, right? Yes. Margaret, you can take it. Yes, the rise in mental health cases in the workplace. And that's why I'm saying research. So who should even be the leader in doing that research? The medics, right? The counselors and psychologists board started working effectively last year, only last year. And so when you talk about psychologists in the counties, by the way, they are remunerated differently. Like if you go to Machakos, it's different. From Kiambu County, Nairobi County, Makueni should be the leading, because Professor Kibudha Kibwana's wife, who really spearheaded, has been my colleague in the field for a long, long time. So I think we need advocates, serious advocates. Some of us talk on TV, but our power is very limited. You have a voice when you're in the government. And that is why when I told you I was humbled for your invitation, even to develop the peer educators manual, I mean it from the bottom of my heart. Because you are in the government, you are the people who even lead in policy development. Do you know there is actually a policy on mental health and wellness in many government offices? And that's why I say, I feel sad. I feel sad for Kenya. Let me come to Kenya because it's my country. we have very beautiful documents for everything, including this workplace mental health and wellness policy. Do you have it at KMTC? Yes. So make sure he gets a copy. Because when I went even to the Home Affairs department, they invite me for this wellness. You find they have the policy. But how is that working? And for sure, psychologists are underrated. And our work is serious. We are the only ones among the health providers who can sit with you for more than 1 hour and get the root cause of your issue or problem. The doctors is not your choice. You can't do it. How many doctors do we have in this country against the number of patients? But if you go to the pyramid of mental health practitioners, the largest workforce are the counseling psychologists or all psychologists. Does that mean we are irrelevant? We are very useful. I'm telling you, if you land in the hands of a seriously competent, trained counseling psychologist, you start self-actualization like the Maslow's hierarchy of needs dictates. Because you become aware of yourself. You become aware of your strengths, your coping mechanisms. Like for today, I will actually give you a whole presentation. It's not because I saw 30 minutes. By the way, I still support Kenya Defense Forces now in a different capacity. Right now, they have their own university college. And I train a lot for IPSTC. For me to be listed in that Eastern African Standby Force, because they were telling me, you're making our soldiers weak. Then I said, give me a chance to do a presentation to the bosses. I'm still waiting to do a presentation to the parliamentarians. Yes. Why? Because when I asked those students over there, when one of our political leaders in this county lost her son, the social media was flooded with what? If people had compassion, would you even write such things? But what does that tell you about the Kenyan nation? We are very sick. But who is there for us? It is very true. We are sick, to be very honest. No, my friend there is saying, no. We are. Why am I saying we are sick? We have our own problems. So sometimes even when we are posting, we don't do what? Process. We don't even process. Later I'm like, ha. Now when you see her crying, when you maybe know, at the end of the day, we get to know personal people's lives. And you're like, wow, why did I even do that? But where are we as a nation? So when you're talking about the psychologist, like my own professional body, we are over now 10,000 members. That's one professional body, Association of Counselors and Psychologists. But how many of them are unemployed? Many. There's one we lost the other day and it really touched my heart. And she came from teaching and she thought she could help more students. So she trained in counseling. She moved from diploma to degree to master's. And her age was catching up with her. No job, no clients. If you go to America, you will find once they have a licensed, well-verified mental health practitioner is funded by this SHA and SHIF you're talking about in their countries, such that you only need to have a list of the gazetted ones, and they can give their specialization, so you can actually go like the way the medics do. If you say, let's Google the best what? Physiotherapist. Si utampata. If you Google the best psychologist, you may not find that. Are we together? So my prayer is you've raised a very good concern. I was even saying that's yours to answer. These ones. Because they are in the government. Me, I am. I say in the government. But I always say once a civil servant, always a civil servant. I think I learned for those 11 years, 12 years I worked with the Teacher Service Commission. You can make a difference. And if you cannot make it in the inside, even when you step out, please do. I lost one student through suicide. And that one student changed my entire life as a teacher. So KMTC, we can vow that we will never lose a student through suicide, because now we know better, because majority of them look at the time they have invested, they look at the money, they look at the people waiting for them to be the doctor in their kijiji, right? And then here there are corners that are not working. And I also want to appeal to you. Substances of abuse, bangi for the students. Chavis, what else do students use? Not these ones in the conference room. They know alcohol. What they are doing to this brain that we need so much is to kill it. And I have given you the best medicine, the breath of. Even when you are jilted, you are let down, you are lefted by your so-called heart what? Heartbreakers. Just breathe in and out. And life goes on. We need you as a medic.
Thank you. Yes, just hold on.
Kumbe. A good photograph here. Yes. Hii si ndio mzuri ndio itaonekana. Hapa ndio mzuri. Oh, okay. Wewe si ulete KMTC uniform. Branding. Branding. Yes.
You also brand.
Yes.
Hey. So Daktari, yes. We don't have any words, and there is no gift that can actually measure up to what you have done for us today. Thank you for your wisdom about not even giving us slides. We needed what you have done today. May God bless you and increase you in every way. Thank you very much. Yes.
KTN mumeshukua. Na kwa nini hawako kama hapo wa Empire was here? Kawaida.
Thank you. Lady, Damalin.
Yes, a gentleman.
Gender balance.
Gender balance.
Yes, yeah.
Yes.
And now these ones I ran with them.
Yes.
I ran with them. Wonderful. Kwani wewe unaenda? Ati okay? Okay. Okay. Kuna ile kamera hii. Ukimaliza watatuambia. Thank you.
Thank you. He's coming. Oh. Okay.
Oh yes. And me and my everything.
Yes.
Yes. Yes.
Oh,
Tafadhali. John.
Thank you so much. Thank you, Daktari. Well done. Thank you. Yes. Okay. Yes. Yes.
Very good. So I will read maybe for one. Yeah. No, you're freaking right.
Thank you for that session. We go back to our paper presentations. Caroline Kimani. Sorry. Yes, I'm confirming whether Caroline is with us. Francis Kagoya.
That he did yesterday.
Oh, did yesterday. Keisha Mendes. Please join us. And Joseph Mangi.
You did that yesterday? Come and sit. Those we are calling out, just come and.
And then Veronica Njaramba. Okay. Fine. So the first presentation, Rachel Ireri, impact of climate change on vector-borne. This was supposed to have been presented yesterday, but we were not able to give our audience. So 2 minutes. Sorry, is it 5 minutes? Yes, make it as fast as is possible.
Thank you, Dr. Good afternoon. My name is Ireri. I'm from Moranga campus. I want to present on the impact of climate change on emergence and resurgence of vector-borne diseases in Kenya. And this study will be based on most of findings that we have. And it was part of the baseline study that is going on in the northern part of Kenya, where we are working towards eliminating Kalaza. So as part of this study, so climate change has become a pressing public health crisis around the world. And even in our country, I think in the last 1 decade, we have witnessed quite a number of changes. And we have seen that diseases patterns worsen in the regions where they do not exist. We can think of COVID-19, which came around 2020. And we actually saw different patterns at different months of the year. This is because climate has been shown to be a significant risk when it comes to multiplying of the microorganisms and also in transmission of diseases. So again, specific infectious diseases may be more significant in some regions or areas than others. And like we will see in a few slides, even in our countries, there are diseases that are common in some areas compared to the other regions. And these differences in terms of the prevalence of these diseases, we can be able to capture them if we do good surveillance of our diseases in these areas. And of course, if we report them very well, and if we document what we are seeing. Remember, we say whatever we don't document, it is not done and it cannot help to make any decisions. So in the past 1 decade, though we will see in our results, we tried to see figures from more than 15 years and our climate projections next 100 years. We have seen different patterns in our in our climate. Sometimes we have a lot of rains, we have floods. Sometimes we have a lot of heat, drought, famine, and many diseases, both infectious and non-infectious, come about and they affect quite a big population. In Kenya, more than 5 million people in the last 5 years have been affected by different calamities that are related to climate. May it be floods, droughts, and all that. And then most of the areas, like we will also see that are affected by these climate patterns are in the semi-arid and the arid areas in the country. So in this baseline study, because I've said we are doing our biggest study in the northern area targeting Kalaza, we wanted to see what were the threats in Kenya about the infectious diseases, and our target was on the NTDs. Though the study is focusing on Kalaza only, but when we were doing the baseline, we looked at around 23 diseases that are notifiable according to the lines. They are either reported weekly or monthly. So we examined 4 diseases, the dengue, chikungunya, yellow fever, and Kalaza. And it's good to note that chikungunya and Kalaza, we have active outbreak or active diseases in the country. Next slide, please. So the methodology for this, we did a scoping review and surveillance from the ministry data from 2007 to 2024. And we sampled 20 counties, like we can see there, mostly the area marked with red. They are the areas where we had higher outbreaks than the number of diseases. I don't know, it's the thinner yellow or it's the darker yellow. Again, you see those areas, we have those 20 counties. 99% of these counties, they are in the semi-arid and the arid areas of this county. So we looked at the ministry guidelines of reporting for this disease, integrated disease surveillance and response. And also, we know that this is integrated to the Kenya Health Information System, where each and every hospital, they report weekly on these diseases. And there are some diseases that we report monthly. Something like yellow fever, it is reported Weekly from the facility level, it's escalated to the county level and then to the national level. Next. The 4 diseases looked at the risk of reported disease outbreaks from the integrated disease surveillance response. And we can see that a disease like chikungunya, when we have one suspected case and one confirmed case, we declare a outbreak. And disease like dengue fever, if you do a caseload for over 5 years and you get one case above the standard deviation, we actually declare an outbreak. Again, Kalaza and yellow fever. If we have one suspected case and one confirmed case, we declare outbreak. Then looking down there, these are the number of cases and the number of deaths that we have recorded over the last more than 1 decade. Chikungunya, we have had around 3,400 cases. This number could differ because like now we have an active disease in the coastal region. I think they're still investigating. So we have had last 6 outbreaks, and the last outbreak was in 2024, which is still continuing. Dengue, we have had more than 4,000 with 3 deaths, and over 16 outbreaks. The last outbreak was last year. Kalaza, which has had more than 5,000 cases, more than 170 deaths, actually carries the biggest caseload of deaths. We have had 22 outbreaks. We currently have an active outbreak in the northern part. And then yellow fever, I think here we are doing better. Maybe it's because of immunization, but still we are not out of the woods, because even when you look at our national coverage for immunization, we are still very low. Next. So if you look at the pattern of this disease in our country, the way they have been trending from these, is this right or left? From where you sit, from their left side, you can see the number of outbreaks have been increasing from 2000 all the way to 2022. Again, we have had very unpredictable number of outbreaks, and we have reported outbreaks essentially in all the 47 counties in this country. They may be different in terms of the diseases. For example, these 4, the chikungunya, the dengue, the kalaza, and the yellow fever, we have reported these outbreaks mostly in the dengue, chikungunya in the coastal area, kalaza in the northern part, yellow fever in the parts of the Rift Valley. Next. Then if you look again at this slide, on this side we have the diseases, the other side we have the climate patterns. If you look at figure 3 above there, between January and April, our temperatures are very high. At the same time, if you look at the rainfall patterns, around between March and May, we have a bit high rainfall. As we come down to May, going all the way to June, our temperatures go down, and again we start rising again. And if you look at the most of these outbreaks, they are reported between January and May. That is when we record most of the outbreaks in this country. And if you look at the figure 17 down there, this has been our temperature patterns in the last 100 years. We have actually projected all the way to 2099. And you can see that during the old seasons and the index levels, they have kept increasing since 2000 up to where we are. And we are projecting that the patterns will actually continue to increase. And even if you look at the tropical nights, and again, if you look on this other side, the number of disease patterns, we have continually to increase. At one time we go down and then we start coming up again. And the pattern of these outbreaks, you can actually check. Between January and May, we report huge outbreaks. Then we go down again, and then from September again, we start reporting outbreaks. Next. So in summary, what are we saying? So there is an intensification in infectious disease outbreaks due to rising temperatures. And again, I can say that due to increasing humidity at different times of the year. And this has been shown that these increasing temperatures and humidity, they expand and extend the life cycle of disease-carrying factors such as mosquitoes, ticks, and parasites. And this could be the reason why we report high outbreaks during those times when it is very hot, and again, we are having rainfalls. And then some counties are also experiencing active outbreaks at the moment. We have active Kalaza outbreak in the northern area, and the coastal area we have chikungunya. Next. So this is my call to all of us here, because we are researchers, that we need to empower the next generation of African researchers to meet the challenges of climate change and the vector-borne diseases, because we have seen it's a problem that is staring at us. And if we don't do anything, the next, how many years do we have to 2099? We are in a bad state if we don't take an action. Thank you.
Yes, Kesha, you are next presenter. Oh, you are next. Come. Okay, Caroline Kimani.
So good afternoon. Yeah. Okay. Yes. So my name is Caroline Kimani from KMTC Muranga. And I'm going to present a study we did about predictors of wound healing among patients with acute trauma injuries. This study was conducted at Muranga County Referral Hospital. Now, injuries contribute significantly to health challenges globally. And we find globally, we are seeing around 5 million deaths because of injuries. And when there are injuries, then we get wounds. And in Kenya, trauma is also, the statistics in Kenya are not different globally. And around almost, actually currently is around over 70% of patients in mainly the surgical wards or generally in inpatient have wounds that we are taking care of, especially in the surgical ward. And from our research, we found that there's a gap on the predictors of wound healing time. Because now when the wound develops because of injuries and then the patient has to stay in the ward for long, that means they are going to incur more expenses. It is also now raising the workload even for the caregivers. And so we wanted to know what are the predictors to wound healing so that now this information can help us in on coming up with policies that are going to inform targeted intervention so that we have optimal management of the patients. So for next slide. So objectives, we wanted to see whether there's any association between the socio-demographic characteristics and the wound healing time, that is the duration. We also wanted to see whether the location of the wound and maybe even the shape of that wound, does it have any correlation with the healing time? And then we also wanted to use the Betz-Jensen wound assessment tool. The parameters in it, there are 13 parameters totaling to a total of 65 when you score it, and seeing whether those parameters have any influence on the wound healing duration. Next. So the methodology, this was a descriptive cross-sectional study, and we conducted it because we were looking at patients with acute wounds, we conducted it in the outpatient and even in the casualty, especially for those patients who came in immediately after an accident or an incident. And we sampled 90 patients. And these patients, we got data using a questionnaire because of their socio-demographic characteristics. And then we used the Betz-Jensen wound assessment tool to assess the wounds at the time when we were recruiting the patient and then following them up and see whether the parameters had any influence on the wound healing time. And then we analyzed the data using SPSS. We wanted to see association between the categorical variables and the time, and of course also the continuous variables on the wound healing duration. So these are the findings we got. The mean age from the 90 patients was around 35.9 years. With we had a small baby, 2 years, and the oldest was 90 years old. In terms of education level, these are the socio-demographic characteristic. Majority of the people who had these wounds had basic education. And for us, basic education was just the education up to Form 4. Then higher education was just contributed to around 24%, and this was because, sorry, not 24. This was the numbers. This was because most of the people with basic education may be doing these manual jobs, which put them at risk of getting wounds. In terms of sex distribution among the participants, you can see majority were males, and I think that one would understand males are the ones who take up more high-risk activities that would predispose them to wounds. Then the next one was in terms of wound healing duration. From the patients that we recruited to this study was conducted between June, July, and August of 2024. That's the time we're collecting data. Over 78% of the wounds took a very short time, that is less than 14 days to heal, that is 2 weeks. And then the rest, 21%, were chronic wounds, because now after that we saw after 14, these were wounds that took more than 14 days to heal. Now, using the what's called the Betz-Jensen wound assessment tool, these were the characteristics that had a severe score. I said there are 13 of them. So the ones that had a severe score was the issue of epithelialization, in terms of the wound, the exudate amount in terms of what was coming out, granulation. And then we found that majority of the wounds had scored above 31.56, and within the BWAT score, that one is actually moderately severe, and of course it makes the wound heal slowly. Next. So in the discussion, we saw there was no association between socio-demographic characteristics and wound healing time. Also, it was noted that wound healing time was not related to location and even shape of the wound. Now, what was significant was the what's called Betz-Jensen wound healing time. Wound assessment tool parameters, and that is what is in the next slide. That these were the ones that had an effect on the wound healing time. That is epithelialization, granulation, and exudate. And significantly worse scores were also there in terms of the wound edges, where the edges were a bit rugged, necrotic tissue, and even peripheral tissue induration. And in conclusion to this, we saw that the parameters in the Betz-Jensen wound assessment tool are stronger predictors for delayed healing, and therefore our research is recommending that we enhance monitoring of wounds. All the time patients come to the clinic or to the outpatient or casualty, we should actually be using this tool, and the ones who score highly means that they have a high risk of having delayed wounds. Then we should be able to prioritize those ones as the at-risk patient. And I want to acknowledge my the following people: KMTC Research Department for funding this study, my colleagues, that is Rachel Ireri, the one who presented, Jane Batia and Veronica Jaramba, because we conducted this study together with them, Murang'a County Referral Hospital, and of course the Murang'a KMTC fraternity. Thank you and God bless you.
Thank you for keeping time. Next is a presentation on prevalence of rheumatoid arthritis. That's Francis. Next is Keisha Mendes, the psychological impact of breast cancer on women in Kibera sub-county, Nairobi County. Karibu.
Good morning.
Good afternoon.
Oh, good afternoon. I stand before you today not just as a student, but as a witness to the silent battles fought by women with breast cancer in Kibera. Battles that go far beyond the physical scars of breast cancer. Allow me to introduce myself. Good afternoon once again. My name is Kisha Mendez, a third-year student pursuing medical social work at KMTC Imenti campus. It's both a privilege and a profound honor to share with you all my research project on the psychosocial impacts of breast cancer on women in Kibera Sub-County, Nairobi. What do we understand by the term breast cancer? According to the World Health Organization, breast cancer is a disease in which abnormal breast cells grow out of control and form tumors. If left unchecked, the tumors can spread throughout the body and become fatal. On a global scale, it's the most common form of cancer and the leading cause of mortality among women. It is increasing in all regions of the world, with transitioned countries having the highest incidence and transitioning countries where breast cancer incidence has historically been low, rapidly increasing. In Africa, breast cancer is the leading malignancy in African women and the second cause of death. Mortality rates are higher and survival rates are lower due to poor oncologic care, lack of awareness, and limited knowledge on breast cancer, especially in rural areas. That brings me to the question, why Kibera? Kibera is a community grappling with poor socioeconomic background, limited healthcare access, and stigma. Women with breast cancer in this area are immensely affected by these challenges, and understanding the experiences and personal narratives, it paves way for tailoring more inclusive and effective breast cancer interventions, shedding light on the overlooked aspects of breast cancer in marginalized communities. I employed mixed methodology to ensure a more holistic understanding of the research questions. It was further enhanced using descriptive case study design, which allowed for in-depth exploration. Using the Fisher's formula because it's widely used and statistically sound, I arrived to a sample size of 79 women, but I successfully achieved a response rate of 72%, which is 57 women who met the inclusion criteria. I used simple random sampling since I was dealing with a homogeneous group and to ensure that the women who met the inclusion criteria have an equal chance of being selected. The questionnaires were researcher administered, designed to produce rich data. The interviews were semi-structured to gather additional insights. The interview guide was developed to steer the interview, ensuring consistency. I used Microsoft Excel to analyze quantitative data and thematic analysis to analyze qualitative data. So this is a bar graph representing the psychological impact. Anxiety, fear, and depression are daily companions for these women. Only 36.8% have admitted to experiencing suicidal thoughts. Imagine the depth of despair that drives these women to such a state. Yet 61% reported to have never received any psychological support, not because they don't need it, but because they can't afford it, because they fear the stigma that clings to breast cancer in the Kibera community. Under social and relationship impact, 43.8% of women struggle with body image issues, feeling less feminine and less whole as a woman. 40.3% face sexual and intimacy challenges, with some partners withdrawing emotionally and even physically. 38.5% have relationship difficulties under the strain of illness and misunderstanding, but a significant portion of 49.1% have reported an increase in family support. 47.3% reduced their participation in social activities, and 38.5% ceasing entirely in their participation in social activities. To the economic impact, a whopping 84.2% struggle with paying for their breast cancer treatment. 43.8% have the reduced ability to work due to the effects, not psychological, but physical effects of breast cancer treatment, like fatigue and pain. And 29.8% had to stop working entirely. Under community attitudes, 57.8% of the respondents experienced negative community attitudes, with 52.6% reported to have been ostracized by people of their own community. Due to the limitation of slides, I will also include qualitative data. The theme that emerged from personal narratives of the respondents was the overwhelming psychosocial burden of breast cancer on these women. And I would like to share with you one narrative that hurt me deeply, that was shared by one of my respondents, and I will read it in Swahili. Ilibidi nichague kati ya kimo na kuwalisha watoto wangu. Saa zingine hata naenda masiku hata wiki kadhaa bila kimo, ndio nipate ya kulisha watoto. Sina hata nguvu ya kufanya kazi daktari, lakini nikikumbuka sina bwana na alituacha mimi na watoto wangu, naamka haraka sana kwenda kuwatafutia watoto wangu. Najinyima watoto wangu wapate, lakini najua Mungu atanionekania na nitapona. To the conclusion, breast cancer imposes severe psychosocial burdens on women in Kibera. This research calls for the urgent need for accessible and affordable mental health services, community education and awareness, and financial support. It also calls for the strengthening of support networks in families and the community. To the recommendations, healthcare providers, this research recommends healthcare providers, policymakers, and community organizations to enhance breast cancer care and awareness by focusing and upholding holistic needs of these women and tailor holistic interventions, transforming these women surviving into thriving. Areas for future research are listed in the PowerPoint. And I would like to conclude by saying, I invite you all to pause and reflect, not just on the statistics, but on the real women behind every number. Each percentage point represents a mother, a sister, a daughter, a wife, and even a friend whose life has been changed forever by the illness. The women of Kibera have shown me what true courage looks like. Despite facing crippling fear, isolation, and hardship, they continue to fight, not only for their own survival, but for the future of their families. Their narratives aren't just narratives of pain and suffering, but are narratives of hope, resilience, and the unbreakable human spirit. It was an honor to listen to their voices, to support them with so much compassion. I urge us to do better, to advocate for real change in our healthcare systems and our communities. Let's live here not just informed, but inspired to act. Let us carry their narratives in our hearts and let them fuel our determination to build a Kenya where every woman, no matter where she lives, no matter where she comes from, she can face breast cancer with hope, dignity, and support. Thank you.
Thank you so much, Kisha. The sky is the limit. It is only the beginning. Right. Our second last presentation, we will end with an international presentation from Malawi, but our second last is going to be by Joseph Mwangi, who is presenting a paper on factors associated with HIV positive serostatus among exposed infants attending mother baby care clinics in Nairobi County. Karibu, Joseph.
All protocols observed. My name is Joseph Mwangi, a lecturer at Tana River KMTC, and also the Deputy Principal of Finance, Planning and Administration. By the way, good afternoon. I could have started with that. And also, something I've noted with the last presenters, all of us have spectacles. I don't know, similarity. They can do research on that. Now I'll be taking you through factors associated with HIV positive serostatus among HIV-exposed infants attending antenatal visits at Mama Rusi Kibaki Hospital, Nairobi, Kenya. Next. We start with the background. we have that 6.7 million people globally who live with HIV, and this is according to UNAIDS 2019. In sub-Saharan Africa, where we account for 25.6 million of these, and 1.7 million children under 15, are HIV positive. 1.3 million HIV positive women become pregnant each year. So you can begin to see the risk. Then without intervention, mother-to-child transmission can range from 15% to 45%. Next. The problem statement is that MTCT, that's mother-to-child transmission, accounts for 14% of all new HIV infection. Quite a big number. Then in 2019, 59% of 1.7 HIV positive children, that is under age of 15 years, lived in East and Southern Africa. So MTCT risk is between 15 to 30 in breastfeeding population, pregnant women, and 5 to 20 in the breastfeeding population of pregnant women. Then what is shocking is that 1/3 of HIV positive children die before their first birthday. Next. So justification is that out of these 1.7 million children under 15 years living with HIV, they live in East and South Africa. Kenya is a high burden country with notable infant HIV prevalence of 6% as of 2018. So despite PMTC programs, in fact, HIV serostatus still persists. So our study will be identifying what are these remaining bottlenecks that we have to do so that we eliminate mother-to-child transmission. My broad objective was identifying factors associated with HIV serostatus among HAEs, and my specific objective was to assess basic socio-demographic characteristics. Also, we wanted to see what are these maternal factors and infant factors, as well as behavioral factors. And we wanted to know whether maternal knowledge and attitude has any effect in prevention of mother-to-child transmission. Next. So methodology, we used cross-sectional design, which was facility-based. We did this at Mama Lucy Kibaki Hospital, and the reason is that it was implementing option B+. This is it's also called test and treat guideline, which says that where we give HIV pregnant and lactating women with lifelong ALTs, irrespective of their viral load. We had a sample of 67 mother-infant pairs, and this was systematically, we used systematic random sampling to get them. The tools we used questionnaires, KIs, interviews, and in-depth interview for the HIV pregnant women. To get the sample population, we used Fisher et al.'s formula, and with a population of 1,000, the sampling was 384, but with our desired sample size of 100, we were able to get 61, and catering for non-response rate, we were able to get 67. Some of the key findings under socio-demographic characteristics, majority of mothers were aged between 26 to 35 years, and that's a whopping 42.6%. 34.8 of them had primary education, and 48.7 were formally employed. So some of the risk factors that predisposes these children was one, late infant registration. We noticed that those infants who are registered between more than 6 months, they were 8 to 9 times more likely to seroconvert to HIV. And some of these issues, we got to dig deeper and saw that they were coming late for infant registration because of either the mothers were given birth in their homes, maybe due to cost and distance. And this keeps me worried because, this kept me worried because on Wednesday I saw some news saying that free maternity services was not budgeted for. So we can see the risks we are going through. If with free maternity we had we're having 8 to 9 risk of seroconverting. What about without it? Then mixed feeding, this one was the highest because it projected that those infants who are fed on substance food or mixed feeding were 10 times, had 10 times more likely to seroconvert to HIV. Those who had no ARVs at birth were 9 times at risk of seroconverting to HIV, which is worrying. Then another worrying factor is that only that 6.8% mother-baby pairs that fully adhere to PMTC protocol. That means they're hoping 63.2% were non-adherence. So on the qualitative area, we issued the things like stigma, long waiting times, fear of disclosure, domestic violence, and transport challenges. Made them not to come to the hospital. Next. I've given 2 scenarios here. One is for the mothers and one for healthcare providers. I can read one of them. One of the patients said that I am working as a domestic worker and it is hard to leave my chores to come for my ARVs and treatments. And sometimes my boss refused to give me permission as I had never disclosed to him that I'm HIV positive. So these are some of the barriers. Also, the other one said that he was violently attacked by her husband because her husband apparently noticed that, discovered that she is HIV positive and she is at home and he will come to the hospital anytime soon. So you can see the risk of disclosure. That. So, and healthcare providers, on their part, they are saying they are busy because they are assigned both PMTC matters and also ANC matters. At the same time, they are required in the wards. So they cannot be able to jump in between. On the peer counselors, they are urging that they be trained and they be facilitated to do community follow-ups. Next. 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 In conclusion, this is a very important slide. Even if you forget everything, know that, Conclusion. Late registration and non-adherence were key risk factors for HIV. Mixed feeding and poor maternal health knowledge worsened the outcome. The cautioning factors were employment and education. The more educated you are, and the more you had the formal employment, the lower the risk of seroconverting. Then some of the key areas is that delayed enrollment, as we have seen, is one of the worst consequences. Suboptimal adherence, that's adherence for the mother and the baby. Then systemic barriers like long waiting time, nurse strikes. In fact, we got one response from one nurse who told that in every nurse strike, we estimate around 12 HIV infant children do seroconvert. Next. So these are some of the recommendations. The first one is PMTC awareness. We should create awareness. We should improve adherence support. That's for the community health promoters. Enhance follow-up. This one you can use peer counselors. We should decentralize services in MCH. That is getting specific nurses for PMTCT only. We support CHV with training and incentives and implement stigma reduction. Next. Thank you so much.
Thank you. This was yes. You'll bear with me. I had thought one of the presenters was not in-house, but I've been informed she's with us, Veronica Charamba. Yes. So we'll get Veronica's presentation before we finalize with the online one. Veronica is presenting on the effect of lifestyle modification on obesity and hypertension control at Thika Level 5 Hospital. Karibu.
Good afternoon. My name is Veronica Jaramba. I am from KMTC Moranga campus, and I'm here to present a component of a bigger research that I did
at Thika Level 5 Hospital on hypertension, and it was an interventional study where the intervention was, it was a large study, but I'm here to present a component of it. And so I'm presenting on effect of lifestyle modification on obesity and hypertension control at Thika Level 5 Hospital, which is in Kiambu County in Kenya, and it's a case control study. That image, I hope, communicates to us that is where we are, and if we are not yet there, we are heading there very fast. So obesity, especially central obesity, is a risk factor for hypertension, and globally the prevalence of obesity has been increasing, and in Kiambu County, where Thika Level 5 Hospital belongs, it is about 55% in women and 28% in men. Management of hypertension involves both pharmacological therapy and lifestyle modification. I know most of us being medics, we think about writing prescriptions, but we forget that there is a lifestyle modification component. So in terms of the objective, the study sought to identify the effect of lifestyle modification on obesity and hypertension control among hypertensive patients at Thika Level 5 Hospital. And the setting is what I've mentioned, the Thika Level 5 Hospital, and we targeted the hypertensive patients in the outpatient and the medical outpatient clinic. It is a case control study. We recruited 200 participants with uncontrolled blood pressure who are older than 30 years. The fact that we were targeting the primary hypertension, and they had to be hypertensive for more than 2 months and already initiated on medication. It was we randomized the participants into the interventional group, that was the home-based follow-up group, and the control group, which was the hospital-based follow-up. So for the interventional group, we did many things. Among them was a monthly review at home by the healthcare providers, and we also sent them weekly text messages where we emphasized on why they need to adhere to medication and the lifestyle modification for 6 months. Among other things we did, we incorporated the family members in terms of educating them on lifestyle modification, and we also created social support for the participants where they would encourage each other on physical activity and being accountable to each other in regarding to lifestyle modification adherence. The control group continued with the hospital review, which was at the discretion of the attending doctor. We used a questionnaire with hypertension self-care activity level effect scale, and the anthropometric measures were also there. We used the same questionnaire to collect the baseline and also the post-intervention data, and we analyzed the data using SPSS version 29. So in terms of the results, as you can see at recruitment or at baseline, all our 200 participants had uncontrolled hypertension, and at the post-intervention phase, in the control group, we had a 52% control, and the post-intervention, and for the home-based, which was the interventional group, we had 92.2% control of blood pressure. By control, we are referring to levels of 140, over 90 for those that don't have diabetes, and for those that have diabetes, 130 over 80 millimeters of mercury. So in terms of our waist-hip ratio, the normal participants, those who had the normal waist-hip ratio for the hospital-based at pre-intervention was 22.4%, and at post-intervention that had declined to 4.1%. And for those in the home-based group, the number had increased from 23.5 to 74.5. For those with abdominal obesity at baseline for the hospital-based, we were at 77.6, and it had gone up to 95.9%. And for those in the home-based, the number had reduced from 76.5 to 25.5%. Obesity, there was also a slight increase for those in the hospital-based from 31.6 to 38.8%. And for those in home-based, we had a slight decline from 40.1% to 39.2%. In terms of DASH diet adherence, I think this is what carried the day. The adherence increased in the interventional group from 2.9% to 76.5%. The physical activity adherence also remained the same for the hospital-based, But for the interventional group, we increased from 31.4% to 60.8%. Strategies to maintain or lose weight. The adherence increased also for the home-based group from 6.9% to 74.5%. In terms of conclusion and recommendation, weight loss and increased physical activity improves hypertension control. Lifestyle modification should be embraced in effective management of hypertension, and health education should be tailored to patients' means of affordability and availability. I wish I can repeat that. You tailor it to affordability and availability. Don't prescribe unga ya yellow, yeah, ugali afya that patients are not able to afford. Don't prescribe green tea that they are not able to afford. Come down to what they are able to afford. Come up with a diet for them based on their means of affordability. And I wish to acknowledge those people who funded this study, the two organizations, the Royal Society of Tropical Medicine and Hygiene, and also the NIHR. Thank you so much.
Thank you very much, Veronica, for that. You've kept time, so that paves the way for our last presentation, very last, which I believe is recorded. And this is on investigating knowledge and determinants of birth preparedness among pregnant women in Mangochi District by Peter Malipa. And this is through the same micro-research collaboration that KMTC has entered into. It's via this that we have gotten this partnership with the members of the micro-research Malawi. And I think this is one of them presenting this paper. So I think it'll be up as soon as our backroom team is able to load it. After that, I said that is the very last presentation, beyond which then we would immediately progress into the closing ceremony so that we can finish with the closing, go for lunch when we are done, so that beyond there, we will be at liberty to leave as we finish the lunch. We would finish the closing ceremony before we go for lunch, and it will be very brief. And so we continue to appreciate your patience. For those of us who are here, yes, I can see the presentation is ready, so we can run it. After which, of course, then I'll ask the presenters to come forward so that each one of them will allow them to answer one question. So select, if you have gotten several, select which one you will answer.
Good morning, everyone. I'm Peter Malipa from Malawi. I'll present on our study findings on the study entitled Investigating Knowledge in Terms of Preparedness Among Pregnant Women in Mangochi District, Malawi. So our group comprised of Good morning, everyone. I'm Peter Malipa from Malawi. I will present on our study findings on the study titled Getting Knowledge in Terms of Preparedness Among Pregnant Women in Mango District, Malawi. So our group comprised of 4 people, myself, Mr. Richard Abudu, who is a senior clinician, Toreno St. Ranges, who is a dental surgeon, and the senior nursing officer, McDonald Gondry. On introduction, we are saying birth preparedness has been globally endorsed as an essential component of safe motherhood program to reduce delays for care so as to reduce maternal and neonatal mortality. So on definition, we say birth preparedness entails a detailed plan that surrounds the delivery of a child. Or we can also say it's a specified action plan and decision made that covers antenatal, intrapartum, and postpartum period of a woman. So in spite of the benefits of birth preparedness, no study has been documented that assesses the knowledge and determinants of birth preparedness in women of district. Therefore, this study wanted to investigate knowledge and determinants of birth preparedness among pregnant women attending antenatal care clinic in Mango District, Southeast Malawi. The study broad objective was to investigate knowledge and determinant of birth preparedness among pregnant women in Mango District. And specifically wanted to assess the knowledge of birth preparedness among antenatal care attendees in Mango District and to identify factors associated with birth preparedness among antenatal care attendees in Mango District. On methods, our study was a cross-sectional study with a sample size of 182 respondents. We used the simple random sampling to select respondents for the study. And the researcher administered questionnaire was used to collect the quantitative data. And the data analysis, we used the SPSS version 24 and to identify associated factors, we use the Spearman raw correlation. Now let's come to the study results. A total of 282 study participants participated in the study, which was a response rate of 99.5%. Majority of the women, 97.6%, had heard about birth preparedness. And the majority of the respondents, 93.7%, got information on birth preparedness from healthcare workers during antenatal clinics. But only 73.3% of the mothers had adequate knowledge on birth preparedness, as they were able to mention at least 4 elements of the birth preparedness. Among the factors associated with birth preparedness, we found that religion, maternal education, maternal occupation, and husband's occupation were associated with the adequate knowledge on birth preparedness. On conclusion, about 73% of pregnant women in the study had adequate knowledge on birth preparedness. And the factors associated with birth preparedness in this study, we found that maternal husband's occupation, maternal education, and religion were factors that were associated with birth preparedness in this study. And therefore, I will recommend that the care workers should continue providing health education on breast awareness for women of reproductive age group using different platforms. Thanks so much for listening.
Thank you. And we apologize for the sound quality, but I want to believe we've largely been able to pick the message from the presentation. So let me invite the presenters present. You'll come forward. These seats have not been occupied for quite a while, especially that one that was for the CS. Kesha, do you feel like occupying that one? Right, so if we have questions for Malipa, we can pass over to Francis, he can communicate. You'll also tell us whether there are any questions from our online audience. But yes, we began with Rachel, who is not with us, but we have Caroline, who presented on the predictors of wound healing time among acute trauma patients in Murang County. Then she'll be followed by Keisha, who presented on psychosocial impact of breast cancer. And then, yes, Joseph Mwangi and Veronica.
So thank you very much. I'm going to use the shortest time. I received 2 questions and I believe they are almost related to each other. So the first one was, how did you take care of the different healing process due to age? And the other one was, did you manage to encounter type 2 diabetic patients with wounds? And what would you comment on wound healing by type 2 diabetes patients? Now, I want to clarify that for our study, we were concerned about acute wounds, and therefore in our recruitment criteria, we were looking at patients who had gotten an injury in the last 48 hours. So, and it had to be something like a cut, a burn. Those are what we were looking at, because we knew the other types of wounds, especially chronic wounds, like what she's talking about, the diabetic wound, would be having other factors that would interfere with the healing time. And so also the aspect of caring for processes due to age, we did not interfere with their care, the way they were receiving care within the hospital. All what we wanted to find out was what were the factors that would affect the healing time. And that's why in our conclusion, we said the assessment criteria for wounds, if used by clinicians, may help in terms of even resource allocation, and therefore they'll be able to define the high-risk patients and maybe allocate more resources to them. Thank you very much.
Okay. For me, I received 2 questions. The first one is they are saying there are so many studies in your area. Why did you use 0.5 as a p-value? I didn't use 0.5 as p-value. I used less than 0.5 so that all my results were statistically significant at less than 0.5. Then about what measures do you use to ascertain these factors? We had various parameters that we are using. For you to know to ascertain the risk, you must have some indicators that should tell you wherever you are doing, either you are doing good or bad. So one of the indicators was the time of registration. We know if you delay in enrolling to PMTCT, and also getting the relevant tests, that is at 6 weeks, 6 months, 12 months, and 10 months, all the way to 24 months. Then if you miss, that's a risk factor. The issue was on adherence. So we looked at those who, among the pregnant mothers and their pairs, able to look at the adherence. So if they were not adhering, that means that's a risk factor, both for the infant and for the mother, because there's another discussion that says that other women were saying, if I'm adherent and my viral load is suppressed, that means that I will not transfer to the infant, which is wrong. Although the infant and the mother should take the ARV and should be adherence. The other issue was on the mixed feeding. We know mixed feeding is a risk factor for HIV transmission, especially for the infants. And for the WHO, it's recommended for the poor income countries, we should practice exclusive breastfeeding. Other countries like UK and US, they have allowed mixed feeding, and that is for formula milk. And this comes with restriction of whether those countries have ensured there are safe water and affordability of the formula milk. Thank you.
So I received a number of questions, but all of them are interrelated. They are talking about for how long was the data collected, and about the hospital-based patients, what happened to them. So I wish to clarify that we recruited our 200 participants over a period of 1 month. After that 1 month, that's when now the intervention was applied. So for those who are on home-based care, that was the interventional group. That one, we did it over a period of 6 months, where I said we would send them messages, weekly text messages. We would visit them at home once per month. And then together with everything else that I mentioned, incorporating their family members and also creating the patient support groups. So for those that were in hospital-based, for them, they continued with the usual care in the hospital. And I say that was under the discretion of whoever was attending to them. But now, when we were collecting the post-interventional data, that is now after the 6 months of the intervention, there's no way all the 210 could come to the hospital at the same time. So to do that, after the 6 months, we visited all the 200 at home to collect the post-interventional data. So the post-intervention data was collected at the same time. That was after the 6 months of intervention. So just the same way as we collected baseline data for all of them at the same time, we also collected the post-intervention data for all of them. Those in the hospital-based and the intervention group, we collected the data after the 6 months of intervention by visiting them at home and collecting data from all the 200 participants. Thank you.
I received one question and it reads, what can be done to make the experience of women with breast cancer better able to cope? So as I had talked about under the recommendations, where the healthcare providers, the policymakers, and the community organizations can enhance breast cancer care and awareness. When you view breast cancer from not just in the medical point of view, but in a holistic point of view, I believe these women will be able to cope. There will be policy formulation, their rights will be advocated for, there will be increased awareness on breast cancer. And yeah, they will also be linked to the resources that they need, whether financial or practical. Yeah, thank you.
Yes, thank you very much. How did the seats test? Oh, yes. We can give them a round of applause to appreciate them. Thank you. You may take your seats. Now, before we begin the closing, we would want to get some feedback. And Francis is going to share a QR code on the screen so that we can take the next 5 minutes or so. We do the feedback and then we'll transition into the closing ceremony. I had asked them to take the seat so that I can see whether I can also sit there. Okay. Even as we do so, I think there was a question that came in late that was related to micro research. and how KMTC collaboration is. So I would ask the in charge of the research in KMTC to state the question and give the answer.
Thank you, Chair. Yes, we got a question here from Emily. She asks, to the organizers of this forum, you talked about KMTC being part of micro research. Where is this, and how do those interested in micro research join? Thank you, Emily, for this question. Micro Research Canada is a partner with whom we signed an MOU last year, but one, so that they can help us train young researchers. Their model is very interesting, very good. And if you listen to Professor Kabachenga in the morning, he talked about the tenets of the tenets that they base the research approach on. And so we have trained with them 2 cohorts last year and last year but 1, and we are planning for another one this year. Their training takes place around October to November. Information about this is normally sent through your principals, and so when time comes for that training to take place, then we make formal announcements and arrangements to have researchers from the various campuses trained. And so we will do this when we invite them on board for the next training. We first trained the in charges of research at each campus, hoping that that information cascades downwards to the rest of the lecturers and then to the students. So Emily, I hope I've answered your question, but you can still do an email specifically on what you want to know about micro research Canada. You do it through research@KMTC, then we can be able to answer those questions. But thank you for the interest that you've expressed. Yes, Chair, back to you.
Yes, we still have 3 more minutes for the evaluation, and then I will transition to the other chair.
Maybe as you do that, I can also make this announcement by one of our student presenters. I request that those students who presented and also who are currently in the room, you requested to maybe after lunch, you take some photos. And I think this one comes from a request by Damalin. So after lunch, maybe you could just meet out there and you take pictures as she has requested. Thank you. Oh, yes. Damalin, put your hand up so that the students see you. I think that is important. Thank you.
I would request members of the organizing committee who are within to move forward and occupy the front, the seats here. Marcela, Dr. Muduka, karibu. I see that a number of us are still doing the evaluation, so I'll allow another 2 or 3 minutes before we begin. Our DDA, who is joining us online, principals and past principals present, members of the organizing committee, presenters, participants, good afternoon. Yes, it gives me great pleasure to arrive at this moment. Every time when you are beginning a project, you would have all the butterflies in terms of how it usually go. And I am grateful that it has gone the way it has, that despite the changes, the challenges that came in with this day having been declared a public holiday, we've been able to conclude our program successfully. If I may report on behalf of the committee, we are greatly indebted to all of you who sent in your presentations that facilitated our being able to host this 8th biennial scientific conference. And I'm grateful to God who has given me the energy and strength, because I think out of all these members seated here, I may be the only one who was also part of the very first KMTC conference way back in 2010. No. Dr. Kibet wants to ride on that one, but I know she was yet to join us. I have seen us grow and improve over time. For the first time, I think this year we had very many papers that were sent in. And we tried our level best to accommodate as many as is possible, so that whereas previously we would probably present just about 28, 27, 29 papers, we created room for 36 oral And for the first time, we also created room for poster presentation just to give as much room as was possible for as many papers that were abstract that were forwarded to us to be able to be presented. I want to encourage us to continue our research endeavor. We may see these as small beginnings, but I'm reminded that a good word tells us that you should not despise the day of small beginnings. And that is the spirit of micro research. Small beginnings that will then mushroom into bigger things. And so I want to appreciate you all, those who have made presentations, be they plenary presentations, paper presentations, and those who have provided audience, both physically and online. And obviously want to invite you to the next one. One of the things I would like to report here is that following instructions is very key. Part of the reasons for many of the papers that then didn't find room to be accommodated was just purely failing to follow instructions. We tell you, present your abstract in this format. But you choose to send it in your own format. So the first thing we'll say, okay, this one is not in the right format. We send it back to you to change the format. But you see, time is not on our side. The time you take to change, if we have moved a step beyond there, it might have been one of the possible best papers, but we would fail to accommodate it just because by the time you now put it in the correct format, we had moved on because time and tide wait for no man. So even as we look forward to our continued engagement, participation in future conferences, please, when we call for, we send a call for abstracts, just read the instructions, follow the instructions, and would not have that room where perhaps something very nice fails to be presented. In fact, I look forward to that day when we'll shift from just having one stream of presentations in one room to where we can have multiple streams because we have very many presenters. And so I'm very grateful for your participation, even during the presentations themselves. I know there's hardly been any presentation where there was no engagement, because I know if you make a presentation, we call you forward here, and no one says anything, you feel sad. But I know we have engaged. And so everyone has gotten something. Lest I say everything, the person who is meant to give the vote of thanks says, I would beg to stop it here. But equally, I did introduce members present of the organizing committee, but it bears repeating. Yes, it bears repeating because probably not all of us were here. These are representation. We are a bigger team than this. Like I said, on Monday, mimi nakuwa mtu wa mkono. Usually would step in for the DDA at the level of the organizing committee, but equally step in for the registrar who is meant to be the chair of the scientific subcommittee of the organizing committee. Next to me is the Deputy Registrar in charge of research, Ms. Gigan, under whose office we normally operate as Secretariat. Dr. Marcela Ogendo from, is it pharmacy? Yes, from Health Professions Education is a member of the committee. Dr. Kibet, Principal Karen, long-term member of the committee. Dr. Manyara from Clinical Medicine, also long-term member. And Dr. John Muduka, yes, the upcoming young tax. Usione mvi. And then at the back, we have Francis Kashanja, a very key critical member of the team. He ensures that we get things done and done the correct way. And so with those many remarks, I don't know whether Madam Didier is online. Yes. So that I can hand over to Dr. Nyawira Mangi, the Deputy Director, Academics, under whose auspices this activity falls, so that she can give her remarks. And then subsequently, I will ask the Deputy Registrar Research to give a vote of thanks. Karib, Madam Didier.
Thank you very much. Thank you, Dr. Aswani, for those remarks and for spearheading the conference together with the team that you have introduced, as well as those who are not present today. So I thank all the members who are in attendance physically and also who are attending virtually. I recognize you all. I thank you for your patience, even on a day like today, which is a public holiday, that you have been present. I'm really grateful that we have had a successful conference. Before we began the conference, we asked ourselves, what does success look like? And I'm very glad to report that the 8th Biennial Scientific Conference has met the targets that we had set for a successful conference. We have done justice to the theme. I thank you for speaking into the theme. In all the activities, in all the sessions, I've been keen to check, is it speaking into the theme about health equity, either directly or indirectly? I've been keen to check about the sub-themes. I want to say they were so wonderfully considered, and that theme is extremely relevant to our country today. Thank you very much. Quality of the presentations was extremely good. I like that, the presenters, I have listened to, I would say the majority of the presentations, very, very good quality of the presentations. So I looked at the posters as well, very good quality of the posters. I listened to the plenary speakers, very good. So the quality has been extremely good. I'm thankful. It means there was good work on the presenters, but also very good work on the team that helped to sift or to assess the abstracts and to give feedback. I thank you. I know we have had, yes, there are still many things we need to learn, like following instructions. So I'm glad that even at this point, we have a chance to hear how we can further improve. I'm glad that most of the research was collaborative. The majority of the papers were presented by a team, even if one person was a key presenter. This aspect of collaboration is really important. In addition, I'm happy for the collaboration we have with Micro Research Canada and Micro Research Uganda, for the collaboration with Mehari, for the collaboration with the other institutions that have been part of these papers. So if you look at the list of the authors, they're from different places, but also if you look at the presenters, even the plenary speakers from the different institutions, I'm very happy that we have collaboration. We had very many abstracts. For the very first time, I think we had over 100 abstracts. So we thank you for the interest. And even if your paper did not make it this time, I am sure it will find voice, it will find place in other areas. This is the first time we've had an international conference. We had papers from the different countries. That is exceedingly great. We are happy that our CS graced and opened the conference, and he even mentioned that research is not a side activity at KMTC, encouraging us to take it forward even more and more. We had several other guests, even who are not presenters. We are delighted that they came. We had very good internet. I'm very happy that we didn't have interruptions of power or of internet. I think the presentations have been extremely clear. Even those who presented remotely, like this morning when the professor from Barara presented, it was absolutely clear. So I'm happy for that. I want to thank all the research champions in the campuses. I want to thank the coaches. I want to thank the supervisors. I want to thank the students. We had excellent presentations from our students. I thank our staff. I thank our principals. I thank everyone in the pathway who have supported this particular work. We had a very good panel discussion. So again, I thank the presenters and also the moderation, the panel discussion. It was a very beautiful start to the conference. The oral presentations, the poster presentations, excellent. The attendance as well has been very good. I'm quite happy that people made it their business to attend and stay in. I didn't see people walking around, except a few, perhaps, who were absent at some of the times. But in general, I'm very happy that we have kept the passion and the momentum very high. So may I, on behalf of the CEO, thank all of you for the work that you have put in, for the commitment that you have put in. There was excellent coordination from the organizing committee, from the session chairs, from the ushers that we had, from the security, from the catering. There was excellent coordination. You realize we also had another major activity going on, but really it went on. They were very synergistic. They went on very well. I thank you. So as conference chair then, I wish to declare the conference closed at this point. I thank you. And as you go back, as you travel, go well, go safely, and enjoy the time. Thank you very much. Back to you, Chair.
Thank you very much, Madam Didier. Actually, I think you have moved the vote of thanks on my behalf. So nevertheless, I'll just amplify what the DDA, who is the chair of the planning committee or the organizing committee of this conference. So on behalf of the planning committee, members whom are seated here, planning committee of the 8th Scientific Conference of KMTC, I would first like to really thank God for keeping us alive, giving us good health, so that we are part and parcel of this very successful activity. Without God, I do not think that we would have achieved the success we have achieved in the last 3 days. Secondly, I want to thank our board of directors, which has always provided strategic leadership in our institution, out of which conferences like this are born. A very special thanks to our CEO, Dr. Kelly Oluoch, for encouraging and supporting research activities in the college, such as funding of research studies, some of which have been discussed in this conference. I specifically also want to wish our thank our very able guest speakers who gave us in-depth and invaluable information that have addressed various important areas of our theme, which was advancing health equity in a rapidly changing environment. Thank you, Professor Sylvester Kimayo. I hope he's still following us. Thank you, Mr. Samuel Ouko, Mr. Stephen Kiboro. Thank you, Dr. Meshak Ndirangu, Mr. Ahmed Nadir Omar, Professor Kabachenga, and Dr. Susan Gitau for your eye-opening and very impactful presentations. Indeed, you are very inspirational, and as an institution, we hope to implement some of the recommendations that you made in your presentations. I also now want to thank our researchers, young and old researchers who made your scientific paper presentations. I acknowledge and appreciate the fact that you worked very, very hard to first respond to our call, which we did early in the year, and you walked the journey so that you met the conference requirements. Some of them were very, very specific, and you worked within the rigid timelines that we provided. You gave us your PowerPoint presentations on time, did your amendments, corrections, and all that. And I do appreciate, we really gave you very, very stringent timelines, but you beat those timelines, and you are here presenting very good quality presentations. Thank you very much. We do not take that for granted. You also patiently have sat for the 3 days doing presentations, and without you, really this conference would not be. Now, I would now wish to just single out a very special thank you to the 4 students who, for the last days, have literally walked with the giants. And thank you. Thank you. You are very brave. You are brave. You answered very difficult questions. You interrogated other presentations. Indeed, your future is very bright, as one of our chairs yesterday said. So keep it up, keep the spirit burning, take this to your campuses, talk to your fellow students, and you are the future that KMTC looks forward to. You are the people to drive the research agenda in KMTC. So kudos to the 4 students. Now, to our audience who followed us online and those who are here physically, thank you very much for ensuring that the sessions were interactive and meaningful. You are very patient, even as the chair has said, patient when we sort of amended the program. You were flexible, and that is why we are here today celebrating a very successful KMTC conference. Last but not least, to the planning committee, thank you. Thank you for the hours that you put in to ensure that we had quality presentations today. Thank you to the media team. You have really ensured that everything flows. Thank you very much to the cameraman down there. Thank you. The registration and ushering committee who are still working, I appreciate you, and the committee also appreciates you. The rapporteurs, the catering team, we acknowledge you. The security team, just as the DDA has said, well done. Thank you also to, whom have I not mentioned here? I think I've basically said it all, but I want to single out part of the secretariat whom I head. I want Francis to stand up. Kindly, Francis, stand up. He doesn't like that, by the way. He doesn't like the limelight. But Francis, from the bottom of our hearts as a team here, thank you. Thank you very much. He's one person who did not sleep. He has not slept to ensure that this just moves. And I know you've seen the posters he has been posting just for people to be mobilized to join this. That, Francis, is not taken for granted. Asante sana. It's only God who will bless you. We will say it here, but God knows what you have been doing. Thank you very much. So asanteni sana. Let's meet another time doing this bigger and better. Asante. God bless all of you. Asante.
Karibu ulitufungulia siku, tufungie na tukitoka tunaenda na chakula, kwa hivyo you can combine everything.
Thank you very much. We are standing. We are going to tell them before I pray. And I think that one will be in order, the students. But before that, I was very much delighted with what Dr. Susan Gitau said here. No, we are in drama. We are not sitting. So I'm one person who has been trained in health action training, and it is a training involving drama. We say that it is an advanced communication in person-centered care. We have been giving patient-centered care, task-centered care, but right now we say it is person-centered care. In the training of facilitators, we have included the drama. And that drama is very interesting because it relieves the tension. It makes you feel relaxed. In fact, when Dr. Susan was telling us to turn the head, sometimes we say, can we yawn for food? So we are going to yawn now. So let us just yawn loudly. You know how to yawn? Ah! Again? Ah! How do you feel after yawning? Very, very good. That is actually a training program which is being undertaken by an organization called Health Training Action. It is based in the UK, an affiliated organization to the Royal College of Nurses. So they trained nurses, and other people in theater also join in. In Kenya, we are only 2 people who have